So good morning. So although we are a small number of people, a small group here, we have to start since always the program is very compact and we should obey the rules and follow the program meticulously. So we'll start with a talk from our friend Bialer from School of Pharmacy and Faculty of Medicine at the Hebrew University in Jerusalem. The title of the talk is on the peaks and graph of alkyl-carbamates in epilepsy therapy. What we have learned in the period between falbamate 93 and cenobamate 2019. Please.
Thank you, Panos. Is it on? Yeah, thank you, Panos. A pleasure to be here after 4 years due to COVID. And it's good to come again tomorrow for a tour, right, Les? Last time it was in his retirement conference when we went to Corfu in 2015, I believe. So, since I've been in epilepsy for 43 years, when he asked me about the topic, Panos, and I chose this topic, so what do we have learned from the carbamate, from falbamate that was introduced in 93 to cenobamate, which was approved in Europe only 2 years ago. So talking about strategies in development ADs, it's anti-epileptic drug. In my humble opinion, there are 5 strategies. Phenotypic approach, structural modification, hypothesis-driven, repurposing, and herbal remedy. So let's elaborate on each one of these strategies. Phenotypic, you take newly synthesized compound with diverse chemical structure, with unknown mechanism of action, and you test him in animal model, and lucky in epilepsy, we have had reliable, predictable animal model since the discovery of phenytoin in 1938. And that's how the carbamate, falbamate, retigaban, and cenobamate were discovered. Second approach is what we call the structural modification. You take existing anti-epileptic drug and you modify it in order to gain better efficacy, better tolerability, or less side effect. That's how brivaracetam came after levetiracetam, falbamate came after meprobamate, and elaborate, or lorcaserin came after fenfluramine, or valnoctamide after valproic acid in my lab. The hypothesis-driven, where you have a single mechanism of action, so-called novel, what we call an hypothesis-driven mechanism of action or target-based approach. That's how vigabatrin, that has been around since 1990 in Europe and 10 years later in the US, were discovered. And there are some in the pipeline, but they are not carbamate, like the soticlestat, currently developed by Takeda, or the XCN11101, which I'll discuss. The fourth approach is the repurposing one. Fenfluramine was in Europe since 1963 as a weight loss drug. In Europe, in the United States, 73. It was kicked out of the market in 97 as a racemate as well as the D-enantiomer. And since we will talk, it has been developed in epilepsy, approved in 2019 in FDA and 2011 in EMA. Lorcaserin followed the same stuff, so here are 2 anorectic drugs, and everolimus is a drug that comes from cancer to epilepsy. And the last is the herbal remedy, and the best example, based on anecdotal reports about CNS activity, is cannabidiol. So here are the carbamate we'll be discussing, and we'll discuss them chronologically. You see meprobamate first. They all bear the alkyl-carbamate. Some are dicarbamate, some are monocarbamate. Then came falbamate, flupyridine, which is only was in Europe, retigabine, BOS, and charisbamate, and cenobamate. So let's go chronologically. Here is meprobamate. It's a 2-methyl, 2-propyl, 2-propadiol dicarbamate 1,3. It was introduced in 1955 as the first anxiolytic agent, which also had sedative and also possessed anti-epileptic or anticonvulsant activity, and was used almost less frequently as an anti-epileptic. extensive work led to its discovery, and actually was it was a blockbuster. It led to the design of meprobamate as a rationally designed anxiolytic drug under the trade name of Miltown. It was a blockbuster in the 50s, and its mechanism of action is enhancing of neurotransmission through modulation of the GABA-A receptor, coupled with the inhibition or blocking of the voltage-gated sodium channel. Its popularity declined as patients reported about dependency, and indeed it's a Schedule 4 drug, a fate later that impacted also its second generation, which were the benzodiazepines. In 2012, EMA recommended suspension of marketing authorization of meprobamate and other containing products, including its prodrug risperidone, due to increased risk of abuse, addiction, and psychomotor impairment. This is a summary of its PK, completely absorbed meprobamate, 10% is excreted unchanged, half-life 10 to 13 hours, low clearance, etc. So, its follow-up is falbamate, very similar in its chemical structure. Instead of methyl-propyl at position 2, it has a phenyl. Comes from the same company, Carter Wallace. It was developed as a structure-activity relationship of meprobamate, and unlike meprobamate, it doesn't possess tranquilizing or sedative properties, and therefore there were no much attention put into it. It's not even a scheduled drug until Wallace gave it to the NIH, NDS, the epilepsy branch, to test its anticonvulsant activity, and indeed it shows or demonstrated remarkable anticonvulsant activity in animal models. And its mechanism of action is similar to meprobamate. It's enhanced inhibitory transmission through the GABA-A receptor and also block sodium current, but in addition, it's also an inhibitor of NMDA receptors. Based on its promising preclinical profile and clinical results, they took pre-surgical patients and they challenged it in the United States, Carter Wallace, as a monotherapy, and it was approved by the FDA in 1993. And due to its popularity, and remember, this is the first drug to be approved in the United States after valproic acid, which was approved in 78. So there was a drought of new anti-epileptic drugs, at least in the US. 120 people were exposed to this drug, falbamate, within a year. And suddenly, report came, it was associated with multiple cases with aplastic anemia and acute liver failure, and its use has been restricted since then, including fatal cases not in Tanzania but in the United States. Currently, the estimated risk of aplastic anemia in patients taking falbamate is about 127 cases per million patients. This is its PK, oral absorption above 80, 50% is excreted unchanged, 50% is metabolized, half-life is a bit longer than that of meprobamate. It's metabolized by glucuronidation, fraction metabolite 20%, by CYP 15%. It's also involved in drug interaction. It's an inhibitor of 2C19 and beta oxidation, inducer of CYP3A4, and thus is susceptible to interaction with carbamazepine and oral contraceptive. And its own metabolism is induced by other inducing anti-epileptic drugs, such as phenobarb, phenytoin, or carbamazepine. The company Wallace also tried a follow-up compound, and that's fluorofalbamate, just introducing a fluoro at position 2. It was a second generation. They claimed there was an reactive electrophilic toxic metabolite that we cannot elaborate due to lack of time, called ATPAL, that the fluorofalbamate cannot produce it. It's more potent in animal model than falbamate. Here it is PK, but its development was stopped due to lack of funds. As I'm saying, where I come from in the agonizing Holy Land, if there are no flour for bread, there is no Torah. You got it, Panos, huh? Okay. Charismamate actually comes This comes from SK Biosciences. This is a South Korean company, and was co-developed by J&J. You see RWJ. But when I was on sabbatical. This was about more than 20 years ago. And when they ran clinical trials, one study was successful, giving it 400 milligram per day. One was not. In terms of PK, the PK was linear at a dose range of 100 and 1500. It's metabolized by CYP, so consequently, its AUC reduced by enzyme-inducing ADs by 35%. Glucuronidation is the major eliminating pathway. No PK interaction with valproic acid or lamotrigine. It got a provisional approval by the FDA in 2008, but it failed to demonstrate consistent efficacy across regulatory trials. And consequently, J&J withdrew its NDA and MAA in 2010. In Europe, in 1984, was this drug, fluperitin, which is also a carbamate. It has been marketed in Europe in 1984, long before its Azor analog retigabine, which is 211. If you look at the structure, this one has a pyridine ring, and this one, retigabine, has only an aromatic, a benzene ring, and that's why we call it the Des-Azor. It was effective as a non-opioid, non-NSAID analgesic drug. It has also anticonvulsant activity, and the maximal electroshock, which we abbreviated the MES, and the subcutaneous metradol, the chemically induced shock, and its ED50 in these models range between 26 and 51. And it acts as an opener of the potassium channel, voltage gain potassium KV7 or KCNQ potassium channel, also is an NMDA antagonist, as well as GABA A receptor. Here it's PK, its availability oral is 90%, it's metabolized by glycine, conjugation or N-acetylation. However, fluperitin interact with warfarin, with paracetamol, and consequently has a hepatotoxic potential. There was not much information on other drugs, and consequently, EMA initially restricted its use for acute pain at above, for young patient due to liver toxicity, and in 2018 it was withdrawn from the market. And its follower and very close is retigabine, which was marketed in Europe under the trade name Troblat. In America they call it ezogabine, that's the generic name, and the trade name was Potiga. It's also a potassium channel modulator KV7, more potent than fluperitin, and it's more selective because it activates the KV7 to 7.5 subtype of the potassium channel, and also modulate GABAergic receptors. And you know the KCNQ have 5 related genes, and they are expressed in CNS, PNS, etc. PK, you see 9 hours. It's a BCS class 2, so F is only 60% due to, and it increases, the bioavailability increases with food, linear PK in the range of 50 to 600, metabolizing, etc. These were the clinical trials that led to its approval. Restore 1 and Restore 2, Restore 1, 2 arms, treated versus placebo, Restore 2, 2 treated arms and 1 placebo. And the Restore 1 had 1200 milligram titrated for 6 weeks. And usually they look at responders, what the percent of patients that experienced more than 50% reduction in the seizure count, and it was 45 in the treated group, compared to 18 in the placebo. In the Restore 1, in the Restore 2, they went smaller doses, 600, 900, and the responder rates were 39, 32, and they are superior to the 70% shown by the placebo. Was approved by EMA and FDA in 2011. However, life is not a rose garden. 2 years later came a FDA warning. Retigabine causes blue skin discoloration and eye abnormality characteristic by quick bend change. And the question, is it reversible if you stop? And all patients on retigabane should switch to other anti-epileptic drug. A few years later, GSK, which was it was a marketed company, withdrew it from the global market due to commercial reason because very, very low sales. The story with fluperitin and retigabane does not inhibit companies to develop other potassium channel modulator, although they are not. Carbamate, one more thing. The story about retigabane does not prevent other company, in this case Xenon Pharmaceutical in Vancouver, to develop a new oral formulation. It's the same drug, and they develop what they call XCN496, a granular sprinkle, a sachet, which is a pediatric suspension of retigabane, 400 milligram in 120 ml of water, which allow flexible weight-based dosing. And you know, all the stories of falbamate, of retigabane, remains here too. A retinal pigmentary abnormality that has been experienced in patients that have been on retigabane for more than 4 years, blue discoloration, etc. Nevertheless, Xenon Pharmaceutical in Canada received FDA orphan drug designation for treating of patients with KCNQ2 mutation with XCN. And my question here, how XCN496 will circumvent retigabane adverse event? Question. There are other, same company, Xenon, also developed another potassium channel modulator, what they call XCN1101, which is a more selective potassium channel modulator. Is a second generation to retigabane, is more potent and target selective, and it's a BCS class 2. You see its structure, it's not a carbamate, and unlike retigabane, they claim that the N-acetyl and its N-acetyl metabolite, he does not possess the prerequisite for the structural feature formation of a pigmented phenazonium dimer, which they claim is the cause of all this skin color, discoloration, etc. It has a long half-life, and they have phase 2 pretty positive results where they gave lower doses of 10, 20, and 25 milligram. And you see that also the sample size is small. With the 10 milligram, they got the responder rates of medium seizure reduction of 33%, with the 46 and 52 at the higher doses, compared to only 18 at the placebo group. The last carbamate I'll be talking is cenobamate. As I said, actually it comes from the same medicinal chemist that synthesized charismamide at SK Biosciences. This is the drug, the structure. It has escalating dose, clearance decrease from 1.4 to 0.4 liter per hour, and consequently half-life increase from 30 to 75 hours. And they run a phase 2 randomized double-blind placebo control, 200 milligram in 200 patients. Suggested mechanism of action, nothing new under the sun. Modulation of GABA A receptor and sodium channel inhibition. You see the structure, the company ran 2 studies. One was what they call C13 and one C17. C13, 250 milligram, long half-life, you can give it once daily. 217, 2 doses, 200, 400 milligram and placebo. And the primary efficacy endpoint were median percent change of, my pointer doesn't work. Anemic. Okay. Median percent change in seizure baseline in 28 of the maintenance period, and responder rates with percent of patients that got more than 50% seizure reduction during that period. And here are the results. 55.6% the median rate compared to 24% in placebo, and the responder rate 50 compared to 21.7. In the other doses or the other study, 35% and 40% in the 155 and 56. So you see superiority of the treated arms compared to the placebo. And the cenobamate study, as listed here, evaluated altogether about 1,000 patients with efficacy demonstrated at a point that the FDA did not require additional efficacy studies. You see it in the graph. And that was more remarkable when you look on 90% response rate, not 50% reduction, 90%. 34 compared to 9. And here you see the 428 and 17 compared to 3, which were significantly superior than placebo. The most striking was seizure-free rate. Ladies and gentlemen, these are drug-resistant patients, refractory, that failed to get any response on all existing anti-epileptic, giving alone or together. And here we see, which was rather unusual, that the seizure-free rate in this therapy-resistant patient was 27 compared to 9 in the 200 milligram, and here you see 1911 compared to 1. However, life is not a rose garden. La vie est dure, ce n'est pas la confiture. So there were 3 cases of DRESS. What is DRESS? Drug reaction with the eosinophilia and systemic symptom. Now the FDA started to with red line. They knew falbamate with its story. They knew some other cutaneous reaction with other anti-epileptics. And they asked to run a phase 3 safety designed to assess whether a slower titration rate will reduce the incidence of DRESS. And you know, whatever the FDA asks, right, Carol, it's become appendix to the 10 Commandments. Okay? Or to the Holy Bible. So, of course, the company ran it. They got more than 1,000 people. And this study, there were common side effects, adverse events like somnolence, dizziness, or fatigue, but no DRESS were identifying, showing that reduced initial dose, coupled with the slow titration rate, appeared to mitigate the DRESS risk. And indeed, it was approved in 2019 by the FDA, in 2021 by EMA, for the treatment of drug-resistant focal onset epilepsy. Now, because of it, it is commercially available in 6 dosage strengths in order to ease the utilization of this slow titration to the neurologist. You start with the 12, there is 12.5 milligram, and every 2 weeks you double the dose. 25, 50, 100, 150 milligram, 200, which is given once daily, and you can increase it or titrate it every 2 weeks. All this led to one of the leaders, Jacques French at NYU, to write this commentary in Nature Neurology. Cenobamate for focal, game changer. The data in this trial, and she is one of the big daddies, or the big mummies of clinical trial of anti, suggests that cenobamate stands out of the crowd. Promise for patients that have been difficult to treat. I'm not an MD, I'm only a humble pharmacist. And my humble opinion, let's be modest. I've been more than 40 years in business, and science always preserves the right to surprise us. So let's be modest in our a priori statement, and let's wait another 5-6 years in order to judge what's the role of cenobamate. In my lab at the Hebrew University of Jerusalem, the School of Pharmacy, we also designed carbamate, and now you can understand why. You got macrolides, falbamate, cenobamate, XCN, because they have potential anti-epileptic activity, but we decided to couple it with sulfonamide moiety. That's based on Gans et al. In 78 showed that synthesized 9 derivatives of 4-amino benzene sulfonamide that showed remarkable MES seizure activity in the maximal electroshock. And there are also sulfonamide like sultiam that has been around for a while, zonisamide, come from Japan, and in the pipeline there is darigabad, which is currently in phase 2, and they all contain a sulfonamide. So we combined these 2 moiety, we got the whole series, and what came out, what we abbreviated here, MPSC, which is a 4-sulfamoyl, you saw it here, see it here, phenyl carbamate, and of course it has a chiral center, and consequently we synthesized the 2 enantiomer, the R and S, and also an analog, which is a shorter analog, then MPSS, which is the 3-methyl-propyl sulfamoyl phenylcarbamate, and it's an analog with 2 less carbon in its aliphatic side chain. So we went and, in collaboration with the NIH, we analyzed the anti-epileptic activity of the 2 enantiomer of the pentyl analog and the propyl analog, the MSPC and the MBPC, and here are the results. These are the enantio-selective anticonvulsant activity. In the MPS, the S was more active, while in the MSPC, there were no enantioselectivity. You see the activities. This is the racemate. This is its 2 individual enantiomer, and similar here, at least in the MSPC, the activity is similar. No neurotoxic was designed, what we call minimal motor impairment, and consequently, the safety index, as assessed by the ratio of the TD50 versus the ED50 in rats following oral administration, was above 10 in the various compounds illustrated here. So in conclusion, since 1955, several alkyl-carbamates were developed for the treatment of anxiety. Meprobamate modulate GABA receptor and induce dependency. That's why it was withdrawn from the market. Several have been shown to interact with voltage-gated sodium and potassium channel. The first one was flopyridine, followed by retigabine. So falbamate, charismamate, and cenobamate block sodium channel. Cenobamate, high degree of efficacy in patients of epilepsy. Such a high efficacy has not been shown since 1993. And the question I pose here is cenobamate unique activity in refractory patient, tempered by the risk of serious rash, is due to synergism between its GABAergic modulation and sodium channel inhibition. I have to say that the 2 of his drugs came to phase 2, one phase 2A and failed, one in epilepsy, one in bipolar. Epilepsy is not a specific disease, but a multifaceted complex of disorder. In addition, we are looking for companies for the carbamate design in my lab. The AD market is crowded, and consequently, much crowded than the neuropathic pain or the bipolar or the migraine prophylactic. Therefore, small to medium-sized companies, SMEs, like to develop new entities for orphan indication, and consequently, orphan indication like the Dravet syndrome or the Lennox-Gastaut is crowded with old and new anti-epileptic drugs. For example, 11 of the 5 new ADs introduced since 2005 versus none between 1988 to 2005 have a license exclusively for orphan disorders, such as Dravet. You see here styropental, cannabidiol, and fenfluramine, Lennox-Gastaut, rufinamide, cannabidiol, fenfluramine, and tuberous sclerosis, everolimus. PK design, my last slide. And second generation approach can increase the potency to overcome adverse events of existing anti-epileptic drugs. It has been illustrated in the road between meprobamate to cenobamate. New AD development, new ADs in development with new mechanism of action have incentive for development, but you have to assume that clinically this so-called ascribe or assign or design mechanism of action will indeed manifest clinically. Currently, it is unknown to what extent a new mechanism of action manifested clinically with patients with refractory epilepsy. In my humble opinion, anti-epileptic development, in addition to knowledge and hypothesis, you need also luck, as we say in my country, mazel, that this hypothesis will indeed be materialized. And as an optimistic person, and a great believer and a big proponent of the Bible, I always quote the well-known proverb from the biblical book of Proverbs. A righteous person, after falling 7 times, will get up again and prevail. Or something which I took from the rowing system and the British rowing system. It is not how many times you get knocked down that counts. It's how many times you get back again, you get back up. Thank you very much.
Thank you very much, Mayor. Okay, we have a question from Carl Peck up there.
Thank you for that wonderful history.
Can you get the microphone? Okay. Oh, speak up. I'll hear you.
No, I've got a hearing problem too. Let's get the microphone.
You know, I was in the artillery. I don't hear so well.
So thank you for that wonderful history. I'm wondering, is there not an HLA profile or a genetic profile that can be used prospectively to identify the risk of Stevens-Johnson and duress, as there is, for Stevens-Johnson for...
Yeah, there is for carbamazepine. There are two genetic factors in Chinese population, okay? I got another example to follow this pattern. You know, in Dravet syndrome, which is a very refractory syndrome in children with epilepsy, 80–85% of these children have SCN1A mutation. It's a gain-of-function mutation. So there are, but there are others, like in the Lennox-Gastaut, which is less, because that's why the Dravet is defined mainly by this genetic mutation that you are referring. Now with carbamazepine, Les wrote a paper, AAPS Journal 2016, and I was a bit involved in it with Don Lovenstein, and he tried to get correlation between BCS classification and BDCS. Look on his page, AAPS Journal 216. I forgot who was the first also. Shen and Bennett. And it was not a real clear-cut, answer there, but there was a trend. You want to add something on that? Yeah, please.
Just stay away from class 2. Stay away from class 2. You don't have Stevens-Johnson syndrome.
Okay, so here you see, Carl, retigabine is class 2. It was not skin, it was cenobamate is class 1. Now that we know the highest dose is 400, we can calculate the solubility, and that's falbamate, I think, was a class 2. Oh yeah, so it's 10, but not all of them.
Thank you for reading that paper, my dear, and
Listen,
also being the reviewer.
You acknowledge it.
Quick question, can I?
Yes, sir.
All these drugs work.
Sebastian.
Yeah.
Paula, yes.
All these drugs work via the modification of the ions flow through the channels, right?
Not only that, but some of them either potassium or sodium.
So how important it is for you to test for the HERG channel inhibition? Is it important at all, or you don't care about it?
What
HERG.
The cardiovascular.
The QT prolongation problem. Is it important for you from the clinical perspective, or you don't care about it because epilepsy is much more important than QT prolongation?
No. That's why you go for selective. You see, it's not a potassium channel. First of all, it's voltage gated. Secondly, you saw the XCN1101. They look only for 2 or 3 subtypes of the potassium. The subtypes that are more available in the CNS than in the cardiac or the PNS. So the idea here, when you talk about either sodium channel, where you may, of course, phenytoin, that's why it's used more as an anticonvulsant and not as an antiarrhythmic. You look for the specific potassium channel which inhibit the subunits that are available in the brain and not in the heart.
The problem with HERG is its promiscuity is pretty high, so pretty much everything binds to HERG. So that's the thing.
Listen, part of the thing that they do, of course, in part of the QT prolongation and any effect there. I don't know if it's a function of the ERG that you are referring, because I'm not so familiar, but at least I know that the specificity. Look here on cenobamate, which is the most remarkable one that came out. The problem was stress. And it has been around, at least in the United States, for 4 years. And cautiously, so far, so good.
Thank you very much for this nice discussion, which can be continued later on. So unfortunately, Milena is not around, and we have to use another speaker at this very moment. So, Maria Bergioni will give us a talk on in vitro evaluation of differences in early exposure. Maria is in the Department of Pharmacy at the University of Athens. Please.
So thank you. I would like to thank you, the organizing committee, for the kind invitation. I think it doesn't work well. It's okay. Thank you. Thank you. And then now we'll pass to another topic, the in vitro evaluation of differences in early exposure. And I will try to find the pointer here. Good. And the focus will be to enabling drug products and conventional products of lipophilic weak base, and how we can evaluate the differences in early exposure by doing in vitro experiments and then pass this data to in silico modeling. And why we selecting enabling product drugs? Nowadays, the new drug candidates often have low solubility, and this low aqueous solubility promotes the enabling products in order to promote supersaturation. And the maintenance of supersaturation in the upper small intestine for as long as most as the dose is absorbed would be a great advantage for the rate and possibly for the extent of absorption. But as always, supersaturation follows precipitation, and the precipitation of the drug in the upper small intestine following transfer would reduce intraluminal concentrations. On the other hand, we have the conventional products of lipophilic weak bases. The impact of gastrointestinal transfer in the fasted state on the absorption rates may be very crucial, because the increased pH that follows the transit from the stomach to the upper small intestine is likely. So precipitation of the API in the upper small intestine following transfer would again reduce intraluminal concentrations. So in total, after administration of enabled drug products, but also conventional products of lipophilic weak bases, drug concentration in the micellar phase of the contents of the upper small intestine can be crucial for the overall luminal product performance. And we are talking about APIs that belong to BCS class 2 that have no permeability restrictions. So drug concentrations in the micellar phase of contents in the upper small intestine are highly sensitive, and the total drug arrival, but also the elimination, and meaning for elimination we say intestinal transit, but also the transport through the epithelium rates, but also the physical state of the drug, meaning amorphous various crystal form in the upper small intestine, are very sensitive, and they will define the final absorption of the API. And nowadays, for enabling drug products or lipophilic weak bases, the usefulness of in vitro and as a consequence of in silico methodologies, which do not take the above considerations into account, is very limited, and the data cannot be generalized. So we have to understand how the in vitro evaluation of drug present in the micellar phase of contents of upper small intestine should be performed. And there are a lot of challenges in this region. First of all is the definition, and the aim is to understand the system. And by saying system, we mean the healthy adults and whatever is defined in the bioavailability-Bioequivalence studies. So based on this guidance, we believe that we have to have healthy young adults, and in our case, we focus to disintegrated dose units only. And then we have to define the operating conditions. Safe operating conditions means we're going to administer the drug product in the fasted state, meaning with a glass of water, or in the fed state, as is defined in the bioavailability-Bioequivalence study, meaning the high-fat, high-calorie meal would consist with approximately 1,000 kilocalories and 60% of fat. So when we define the system, then we have to understand the difficulties in understanding the system. And the difficulties is to define and try to fit a bit with the increasing variability of the system, meaning the number of volunteers that are included in such a study versus the ethical issues in order to introduce a big number of volunteers in the study, but also the cost of running such studies, and also the limitations of the applied experimental methodology in order to understand this system and how we can define how the transit is made or how the concentrations in the gastric or in the intestinal fluids are. So there are two different techniques nowadays which try to understand the system, and one technique is the direct sampling from the gastrointestinal lumen, and the other one is the imaging techniques, as an example of the MRI techniques. And even though we have progressed the last 20 years in relation to these issues, there are still knowledge gaps in understanding the system. So there are no data in relation to the drug presence in the micellar phase of contents at midgut or at distant instant testing, because it's not easy to go there and pick samples. On the other hand, the impact of gastric environment in the fed state of the disintegration of a dosed unit is still an open issue, although there are a lot of data in relation to the pellets. On the other hand, the drug, not just the gastrointestinal transfer, but the drug gastrointestinal transfer process in the fed state is still unknown. And then we have no data after the recently proposed low-fat meal, the new meal proposed from the guidance of FDA last year, where they proposed a low-fat meal of 500 kilocalories. And then, after defining the system, we have to understand the required level of simulation of the system. First of all, we have to define the level of simulation of bioavailable media that we're going to use. By now, 4 different levels of bioavailable media have been proposed. In level 0, only the pH of the buffers or just water are used for the dissolution medium. In level 1, apart from the pH, the buffer capacity of the medium is also simulated. For level 2 bioavailable media, in addition to the pH and the buffer capacity, the presence of bile components, lipids, lipid digestion products, and osmolarity is also adjusted. And for level 3 bioavailable media, apart from all other parameters, the presence of proteins, of enzymes, or for viscosity effects are simulated. So in order to have a more reproducible and more close to low solubility and lipophilic compounds environment, usually level 2 or level 3 media are used. In addition, the simulation of the total drug arrival in the small intestine, but also the elimination, meaning the intestinal transit, but also the epithelium transport rates have to be simulated. And then we have to understand the reliability of the in vitro data. And this is easy when talking about concentrations in vitro, because it's easy to compare with the concentration that I have been collecting from the lumen of healthy adults. But it's still not so easy to compare and to understand what is meant by supersaturation ratio, in vitro precipitation rate, but also precipitation time based on in vitro data. And now I would like to present you what we have done the last 10 years in our lab in order to understand the system in the fasted state. First of all, we try to characterize the system in the fasted state conditions. For this purpose, we administer dipyridamole and ketoconazole, 2 lipophilic weak bases, 2 single dose per case in 12 healthy adults. This means that we administer the APIs in the fasted state with a glass of water via double lumen tube to the stomach of healthy adults, and we aspirated samples from the duodenum. And based on this data, we were able to reproduce 48 individual data sets in vivo. And then we make dose normalized of the total drug amount per volume of intestinal contents versus time post-dosing, and we were able to have this more than 300 time points. And then we fit this equation to the data in order to estimate the first-order gastric emptying rate constant, the first-order upper small intestine emptying rate constant, but also to estimate the volume of upper small intestine contents. Based on this fitting, we were able to understand that, based on our data, the half-life of gastric emptying was approximately 18 minutes, in the fasted state. The half-life of duodenal emptying was approximately 2 minutes, and the volume of duodenal contents was approximately 30 ml. And this was based on the assumption that the initial volume of gastric contents was 1 glass of water, meaning 250 ml. Based on these parameters, we set up the BioJIT. The BioJIT stands for Biorelevant Gastrointestinal Transfer System. And I would like to present you this system. We used the commercially available mini vessels from Eureka for the dissolution, and the experiments were carried out at 37 degrees with the pad rotating at 75 RPMs, assuming gastric emptying half-life of 15 minutes. Then we have a dissolution vessel, which represents the gastric compartment with the initial volume of 250 ml, and the duodenal compartment with a constant volume of 40 ml. Then we use these parameters in order to estimate the transit, the flow rate from the gastric compartment to the duodenal compartment, and also the emptying from the duodenal compartment to the exit. For practical reasons, incoming flow rates are changing every 10 minutes, and sampling is possible at the midpoint. As initial concentration of gastric contents to simulate the gastric contents, we use the level 3 fasted state gastric fluid, the level 3 FAS-SGF, and for the duodenal compartment we use the level 2 as relation to the simulation of fasted state simulated intestinal fluids called FASIF. Then we have a reservoir compartment which contains a series of phosphate buffer solutions containing sodium chloride, bile salt, lecithin, and these buffers are pumped from the reservoir compartment into the duodenal compartment in order not only to maintain constant the volume of 40 ml in the duodenal compartment, but also to maintain unaltered the composition of simulated duodenal contents during the experiment. And how we handle the samples that we take from BioJIT. First of all, we take a sample in order to measure the total amount per volume, the total presence of the API in the duodenal compartment. Then we filtrate this sample and we divide this into parts. The first part is used in order to measure the dissolved API, meaning the concentration that is dissolved from the total amount per volume, and from these two values we are able to estimate the percent solid fraction, and in case that here we have solutions, to estimate the precipitation. The other part is used in order to measure the solubility of the API in these contents, and after estimating the equilibrium solubility, we are able, from the concentration and the equilibrium solubility, to estimate the degree of supersaturation. And we have used this setup, and we were able to predict the micellar drug concentration that we have measured, or other colleagues have measured, in the upper small intestine for APIs like albendazole, parapomycin, posaconazole, itraconazole, or ritonavir. And this correlation seems good, and I would like to show you two representative examples. The first one is ritonavir. Ritonavir is a weak base, and we tested the Norvir tablets, is amorphous solid dispersion tablets administered in healthy adults in the concentration in the dose of 100 milligram. And in this figure, we can see the apparent concentration of ritonavir versus time, and with the white squares, we can see the individual in vivo data that have been collecting from healthy adults from the duodenum, and with the gray area, the mean and the maximum area that is created from in vivo data, and with the yellow circles, we can see the BioJIT data. So we can see that the BioJIT data are within the area of the variability of the data. On the other hand, we have another example. We have the albendazole suspension, and also in this case, we can see the in vivo data with these green box plots, and with the yellow bullets, we can see also the BioJIT data. So we have verified that our system is working for this weak base and this amorphous solid dispersion, meaning by enabling formulations, and we want to see how this data can be useful in order to estimate differences in early exposure between 2 or 3 different dose, or different formulations. And first of all, we started with fenofibrate as an example. Fenofibrate was administered in healthy adults as solid dispersion capsules of 54 and also of 160 milligram, and we had the data, plasma data, for this administration. And we tested both doses in the BioJet system, and we tried to estimate the concentrations in the duodenal compartment. In this figure, we can see the apparent fenofibrate concentration in the duodenal compartment of BioJet versus time, and with yellow bullets we can see the high dose, and with the blue bullets we can see the low dose. With gray bullets we can see the solubility in these samples, and we can notice that in all cases contents of the duodenal compartment are supersaturated with fenofibrate. Then we took the plasma data and we calculated the AUC plasma data the first hour after administration in order to estimate the early exposure. And here are the AUC values for the low dose and the AUC values for the high dose. And then we estimate the ratio of the AUC plasma data, which was 2.4. Then we estimate the AUC BioJet data, meaning the AUC after the curve of the low dose and the AUC after the curve of the high dose. And then the ratio of these two AUCs resulted to a ratio of 2.6. This means that differences of AUC 1 hour after the administration of these two doses or after the initiation experiments of two doses were statistically significant for both comparisons and similar with the observed data in vitro. And we continue with more than 20 APIs, and we try to understand and to evaluate the impact of formulation, but also of dose, on early exposure after the administration of APIs as products that are or disintegrated solid dose units, suspensions or solutions, where we had data to fasted adults and administered with a glass of water. And we tried to run the linear regression analysis for assessing quantitatively the relationship between this ratio, meaning the ratio of AUC of plasma versus the ratio of AUC in BioJet. As independent variable, we have the BioJet AUC ratios. And as we can see here, this is a straight line with a slightly good R correlation, and with the white bullets we can see the studies that came from crossover clinical studies, and with red bullets the parallel clinical studies. As we can see here with the confidence intervals of our line, we can see that crossover studies perform better than parallel clinical studies, but in any case we have a good correlation. So we think that this BioJet system could facilitate formulation and dose selection, but also could support regulatory decisions. But also, we have used BioJet data in order to inform PPK modeling on precipitation kinetics in the upper small intestine. And as an example, we used compound B. Compound B was a weak base with log B of 2.9, and the precipitation time that GastroPlus is using was estimated by modeling BioJet data. For this purpose, an advanced compartmental entrazine model, the ACAT file of GastroPlus, was generated to simulate the conditions of the BioJet system, and then an effective mean particle size was first fit to the dissolution data that was generated in level 3 FICE SGF, meaning in the gastric compartment of BioJet, in order to estimate the input dissolution kinetics for the system. The resulting particle size that we have used and was estimated from the ACAT model was 100 micrometers. And then we generated intraluminal data in GastroPlus using different precipitation time, as GastroPlus used this term in order to estimate the precipitation in the cases when simulations are performed. And the default value from GastroPlus is usually 900 seconds, but we use different values, and we saw that based on BioJet data, precipitation time is to be prolonged, but it's hard to accurately differentiate between longer precipitation times, as you can see here. But in any case, longer precipitation times of 3,000 seconds or 10,000 seconds predict better the 15 minutes and the 45 minutes. So based on that, we performed the simulation in order to predict the plasma profiles. And what we can see here is that the longer precipitation times, like the 3,000 or the 10,000 seconds, allow for a Cmax prediction within the variability of the data, better than the default value that GastroPlus predicted or lower precipitation time. So this is a way to somehow use our data in order to find a way to find the appropriate precipitation time in a model setting. And there are pros and cons in all systems. So we have some issues that are challenging, and we have experienced this with BioJet, and it will be nice to see also if other in vitro systems would predict such difficult cases. And one difficult case is the nanocrystals. And in this case, we saw that slight elevation of the pH in the gastric compartment of the BioJet system may be needed when nanocrystals of weak bases are under investigation. This means that instead of using a pH of 1.6, maybe a pH of 2.2 is more accurate. And on the other hand, sometimes BioJet cannot work so perfectly. And this is the case when the products under investigation are not degrading, and this is normal because not the total amount of drug is transferred to the small intestine, and also when the volume of co-administered water is not controlled in the clinical study. This is also expectable because when we have 1 glass of water or 20 ml of water, the transit is completely different. It would be nice also to see if other setups could predict such deviations. And now we would like to pass to the third state. There is still to know a lot of things. We have first of all to understand the key characteristics of the gastric contents that control this integration of those units and how we can predict this in vitro. And next week we're going to present a poster at the UFEP's annual meeting in Lisbon. And then we try to characterize the drug gastrointestinal transfer process after disintegration in stomach. We have submitted an abstract to the APS. Maybe in Orlando we'll have the chance to present these results. But also now we are trying to evaluate the drug presence in the micellar versus the colloidal, and meaning colloidal, meaning the non-droplet phase in the fed state of the gastric contents, but also of the intestinal contents. And we're happy because we have participated in PEARL and Marie Curie reactions a few years ago. These Marie Curie reactions gave us the chance to study these fed state conditions for the first time. And now with another Marie Curie reaction in which we're participating, but it's called InPharma, we have also the chance to perform a clinical study to healthy adults in order to characterize the contents of healthy adults, gastric contents, intestinal contents after the administration of the high-fat, high-caloric meal and get information from these contents. I hope that in the next conference I will have the chance to present you results in relation to this. So at this stage I would like to thank my colleagues from the National Kapodistrian University of Athens, Professor Christos Repas, and also the PhD students, the former PhD students that have worked on this, Alexandros, Christina, Konstantinos, and Dimitris. Also, our medical doctor, the director of the gastroenterology unit in the Red Cross Hospital of Athens, because his help is very crucial in order to incubate the healthy adults and be able to aspirate samples from the stomach and the small intestine of healthy adults. Our colleague in MSD, Philippos Kesisoglu, but also the companies who shared with us their data and their formulation, and now some of them have already BioJet in their premises. And with this, I would like to thank you.
Thank you very much, Maria. I'm sorry, this is too aggressive. Anyway, so the paper is now open for discussion. Have any questions? Okay, please. Oh, let's start from Clive, but a very short question, then a second one, a third one, in a matter of 3 minutes. Okay.
Very quick, Mary. Thanks for a lovely presentation. We ran into huge problems. With trying to look at the lifetime of a micelle because it changes in all systems. The other thing that we ran into a problem with is that we tried to chill the samples and the material crashed out and it wouldn't go back in. So how long have you got operationally in order to be able to take the samples and get them to the first stage of your system?
You mean in vivo?
Well, yeah, in vivo and in vitro.
Yes. That was the main problem when we designed the study. That's why upon collection of the sample, we separate the samples and we put in each vial volume that we want to measure. So we dilute directly to the mobile phase or the acetonitrile in order to ensure that there is no crash out of the API, and we know exactly the filtrate, let's say, components, or the total amount per volume, or after acidification, what we get in the supernatant, meaning the apparent concentration of the API. And exactly the same we are doing in the Biojet experiment. We don't keep the samples in -70 until analysis, but we pre-weight, let's say, the sample in order to ensure that API is there and not change phase or anything else.
Thank you.
Okay, Dr. Fatouros, please.
Maria, excellent presentation. I have actually 2 questions. I have the feeling that these models are within the family of lipid digestion model, our team, or this kind of group of, let's say, pre-screening models, right? So my question is, do you consider this as a pre-screening model? And the second one is, so far, my understanding is that in these models we have either solubilization or dissolution, but still we have the step of the absorption. So have you considered also to include to your model an extra step for the absorption, for example, by using Kapodistrian cell monolayers, or for example, ex vivo models and rat tissue or something else? Thank you.
Thank you, Dimitris, for the question, and I will start with the second one in relation to the absorption compartment. And I would like to highlight that our data have been based on in vivo data and actual concentration, intraluminal concentrations, and the fitting have been performed to this concentration. So the transit that we assume that have been done in the duodenal compartment have 2 transits. The transit that goes from the upper small intestine to the lower small intestine, meaning from the duodenum to the midgut, but also the transit through the epithelium. So this flow rate takes into account both mechanisms. And in relation to the other question, we don't using the lipolysis model, but we use level of simulation that already took into account this, meaning that we have the level of simulation as a snapshot media and not a continuous lipolysis model. Thank you.
Oh. Thank you. Would you like to have a question?
Just a quick question. You were with me, in Leuven, and you heard, sort of this new minimal TIM model. Mm-hmm. Can you just comment, how your system is different than this desktop TIM that they were publicizing?
Yes, sure.
What's the advantage?
It's another concept of seeing the in vitro modeling. We try to have more simpler model and not have so complicated, because the TIM model is nice and it's a bit more complicated in terms of running an experiment within 1 hour, because in our system in 1 hour we can perform a single experiment, so we perform all our experiments triplicated within the same day, and we try to have just the snapshot of the early exposure and not the total exposure. TIM is more for the total exposure, let's say, and to have the whole picture of the results. Although I'm not completely sure how I can extrapolate the results from TIM to PPK modeling and how this can correlate with in vivo data sometimes.
I didn't mean full TIM model, this new desktop 2 compartment.
Yes.
This smaller.
So, I really thank you very much once again. Okay.
Thank you.
The next speaker is Professor Sofia Dimitriadis from the University of Patras. She originally graduated from the University of Athens. She got her PhD and moved 200 kilometers to west in Peloponnese, where she created a lab in pharmaceutics. Okay. The title of the talk is Dual Ligand Targeted Doxorubicin Stealth Liposomes as Therapeutic Against Triple Negative Breast Cancer. Thank you.
Okay, hello. Thank you for the introduction and thank you for the invitation to be here today. I'm going to talk about a different story. We work with liposomes, drug delivery. So this is the title of my talk, as you already heard. And it has been performed in the Laboratory of Pharmaceutical Technology in the University of Patras and the fourth institute which I collaborate with also in Patras. Okay, the outline is seen here. After a brief introduction, I will get into the objectives, the methods, results, conclusions, and future perspectives. For an introduction about liposomes, you probably all know what liposomes are, especially after the COVID vaccine. They are currently in clinical use for several years, many years actually, with numerous therapeutic advantages due to their excellent biocompatibility. Here you see a time frame of the evolution of liposomes from their invention, from the time they were invented up to today. Several types of liposomes have been used or tried to be used for drug delivery reasons, and we have several products in the market. In the last years, we had the introduction of the liposomal mRNA vaccines that were given to most of us, I guess. And there are still several let's say, challenges in the liposome field, and one of it is the translation of immunoliposomes, as we call them, or actively targeted liposomes. So this is what I'm going to target on today, mostly. Here is just a table which shows all the products that are in the market for injectable formulations. And the ways that have been used in the literature and also in our lab to enhance the targeting efficiency of nanomedicines, which is one of the reasons why today we don't have a targeted, actively targeted formulation of liposomes in the market, one is to use a more localized route of administration. In our lab, we have tried to use intrapleural injection for lung cancer, and we had very good results. We can do this also by adding a physical targeting method in order to enhance the molecular targeting. We have used magnetic attraction, and you will see a lot of such studies in the literature. People also try to use bioinspiration in order to get higher targeting efficiency by using some information from exosomes or extracellular vesicles. In our laboratory, we try to do this work with cellular vesicles to target the brain, and we had some good results in the recent years. And another way is to enhance the anti-cancer potential if you want to deliver an anti-cancer drug, by including in the liposome some lipids that have intrinsic anti-cancer activity. And we have done this in our laboratory using arsenic-containing lipids or arsonolipids and producing arsonoliposomes, as we call them. What I'm going to talk about today is by using more than one ligands and targeting more than one receptor, if we can have a higher targeting efficiency. So actually, the objective of today's work is to develop dual ligand targeted doxorubicin stealth liposomes against triple negative breast cancer. This is one of the most difficult today types of breast cancer to treat, and the most deadly type, actually. So what we selected two receptors to do this. We wanted to target the folic acid receptor and the hyaluronic acid receptor, which are both located on triple-negative breast cancer cells. And the methods that we used, first of all, we had to synthesize lipid PEG conjugates in order to attach the folic acid or hyaluronic acid on the surface of the liposomes, but we didn't want to do this on the surface of the liposomes because it would be coated also with PEG in order to make it stealth. So what we wanted to do, it was to, if we go to the next one, is to have a PEG moiety in between in order to have our ligands overexposed on the surface of the PEG. So first of all, we synthesized this folic acid PEG lipid conjugate. You see here the path that we used. I will not go into details due to the sake of time. And also the lipid PEG hyaluronic acid conjugate that we synthesized. This was done in 2 steps, as you see over here. And then we went on to prepare the liposomes. For this, we used microfluidic mixing methods using precision nanosystem apparatus. And after that, we actively load doxorubicin in the liposomes by a known technique by which you can have a very high encapsulation, close to 100%. To characterize the liposomes, we performed ELS, we evaluated the encapsulation efficiency, the release of the drug, and also the integrity of the liposomes, also in presence of proteins, in order to ensure that they will be stealth after we inject them in vivo. For the experiments, we used 3 types of cells. The 2 of them, all of them are breast cancer cells. The 2 of them are triple-negative breast cancer cells, MDA-MB231, which are known to overexpose and overexpress folic acid and hyaluronic acid receptors. The same with 41 triple-negative cell line. And then we also use the MC7 cell line, which is not triple-negative, but overexpresses a little less both of the receptors, and we expect to have a lower targeting in order to verify if our liposomes are prepared correctly. So the liposome targeting potential was investigated in these 3 types of cells by performing binding, uptake, and targeting potential studies, by flow cytometry, receptor blocking studies, and confocal microscopy. And then we did mechanistic studies with flow cytometry, annexing PI kit, in order to see if our liposomes cause apoptosis or necrosis, or what is the mechanism of action. And also we investigated the cytotoxicity of all the liposomes that we prepared by the MTT. The results now will be shown. So first of all, I will show what we did to optimize liposome formulations, then the physicochemical properties of the liposomes, then the interaction of liposomes with cells, targeting potential, uptake, and binding, and the anti-cancer activity mechanism at the end. As we see over here, in order to optimize the folic acid liposomes, we selected to use 3 different types of PEG in between, PEG 2000, PEG 400, and PEG 5000, in order to see which is the best length in order to have a better targeting of our liposomes. And in the studies that we performed on the 2 types of the cells, 41 and MDA, we saw that in both cases we had higher targeting if we used the spacer, let's say the PEG spacer, with a molecular weight of 3,400. So we selected this, and then we did studies to see which is the density of the ligand that we have to use. So we investigated 4 different densities, 0.1%, 0.5, all of these are mole percent, 1 and 2%. And we saw that in 41 and also in MDA, the 1% folic acid liposomes were the ones that gave us the higher uptake by the cells, and we also confirmed that the presence of these ligands on the liposomes will not disturb its ability to be loaded with doxorubicin. So we went on to optimize also hyaluronic acid liposomes. In this case, we selected from the literature the 0.1% mole and the 10,000 molecular weight hyaluronic acid. We selected to prepare non-pegylated and pegylated liposomes because hyaluronic acid is very huge with a 10,000 molecular weight, and we thought it might be okay to add it without PEG on the liposomes, but this in fact was not correct because we saw that when we used the non-PEG liposomes, we had lower targeting compared to the pegylated ones in both types of cells, and also we saw that the non-pegylated hyaluronic acid liposomes were not very stable because they were losing encapsulated fluorescent marker calcium in this case when we incubated in presence of plasma proteins. Again, we saw that there was no disruption to load the pegylated or the non-pegylated liposomes with doxorubicin. We didn't have any effect on the encapsulation of the drug. So we went on, characterized, we selected the best formulations, we characterized, and we used them for the studies that I will show you. So here we see that all of the liposomes have mean diameter in the nano range, around 100 nanometers, low PDI, and very high encapsulation of doxorubicin. So we also saw that in all cases, the liposomes are very stable in absence and in presence of proteins. So this means that we suspect that they will have stealth properties and circulate for a long period of time after we inject them. This was true also for the folic acid, for the hyaluronic acid, monotargeted, and also for the dual-targeted liposomes. The release of doxorubicin was similar with a control for all the types of targeted liposomes. Here I show also only the folic acid, but this is true for all of the liposomes, even the dual-targeted. And this takes us to the uptake studies. So first of all, in the MDA cells, which are triple-negative cancer and overexpress both receptors, we see that then when we go from the control with no receptor to the ones with folic acid or hyaluronic acid, we have doubling of uptake. And when we go to the dual targeted, this uptake is enhanced many times. We have a cut here, as you see. The dual targeted liposomes are much better to target the cells. The same is true for the 41 cells. Again, we see compared to the control that the mono-targeted are much better in terms of uptake by the cells, but when we have the dual-targeted, we have almost double targeting, double uptake. And when we go to the MC7 cells, we see that the mono-targeted liposomes do not really work in this case, and this is because they do not overexpress at the extent compared to the other cells these receptors. Only the dual-targeted gave a very clear difference from the control, and significant one. So this verifies possibly that the targeting is via the two receptors. Here we see all the different cell types together with the different types of targeted and non-targeted liposomes. In all cases, the dual-targeted liposomes perform much better in terms of uptake by the cells. And we confirmed this also by confocal microscopy. I will go to the next slides, which are more analytical. Let's go to this one, where we see for the MDA cells, again, we see over here that compared to the control, the folic acid and hyaluronic acid liposomes work better than the control. In the dual targeted liposomes, we have a little bit increase, but not significant compared to the hyaluronic acid ones. When we go to the 41, again, we confirm that high difference between the mono-targeted and the dual-targeted liposomes. And for the MC7 cells, only the dual-targeted liposomes have and the hyaluronic ones have a small effect on uptake. In this case, the dual, of course, it's larger. But compared to all the other cells which overexpress more the two receptors, there is a big difference. So we also did blocking studies. By blocking the receptors on the cells before we incubate with the liposomes, we should see a reduction in the uptake. And we did this for the MDA cells, and we see when we blocked the folic acid receptor, we had a substantial decrease in the uptake. The same is true for the hyaluronic acid receptors on the same cells. So we see that both of the cells contribute in the uptake of the dual targeted liposomes, both of the receptors, excuse me. For 41 cells, again, the same stories because they overexpress both receptors. So when we block folic acid or hyaluronic acid, again, we see a huge reduction in the uptake by the cells. And for the MC7 cells, as you see here, we didn't have any significant difference after blocking the receptors, which proves that in these cells we don't have targeted as we expected. So going on now to the activity studies, we studied by flow cytometry and annexing 5 propidium iodide staining. What is the effect of DOX-loaded liposomes in this case? In the previous study, we just used liposomes that were loaded with 2 fluorescent markers, FITC and rhodamine. And here we use doxorubicin, so this is efficacy studies, let's say, in vitro on the cells. In the MDA cells, where we see the difference between untreated, free doxorubicin, control, FA liposomes, hyaluronic liposomes, and dual-targeted liposomes. And to make it clearer, here we see the difference in the amount of viable cells and late apoptotic cells. It's clear that the hyaluronic liposomes reduce the hyaluronic acid labeled liposomes and also the dual targeted reduce the number of viable cells many times and increase the late apoptotic cells. So these type of liposomes act by producing late apoptosis to the cancer cells. For the 41 cells, again, we see a difference between the dual targeted and the monotargeted. Here, it's shown better, where we see that the dual-targeted liposomes produce a marked decrease in viable cells, decrease also in early apoptotic, and a very huge increase of the late apoptotic cells. So they cause late apoptosis at a higher level. And for the MCF7 cells that do not overexpress these receptors, we see that the differences between the different groups are limited, are not so high, and we see this better over here. So we prove the case that the targeting is done via the 2 receptors. And when we look at the cytotoxicity results, we see that all of the types of liposomes that we prepared are not so toxic for HEX cells, which are normal cells, but are much more toxic for the cancer cells. But the different types of liposomes do not induce different, let's say, degree of toxicity. So this proves that more or less all the liposomes have the same toxicity, but we have the targeting that can cause the apoptosis to the cancer cells. So here are all the conclusions. We have developed dual-targeted liposomes with, in order to target both the folic acid and the hyaluronic acid receptor at the same time. These were developed. They had nanosite, good integrity, high loading, high retention of doxorubicin in the liposome, and stealth properties. We proved higher binding and uptake of the dual liposomes compared to the FA and hyaluronic acid mono-targeted. We proved early and especially late apoptosis of triple-negative breast cancer cells, and now we are currently running out in vivo studies with these liposome types. Before thanking you, I would like to thank some of the people who contributed in the early part of this work from my lab, and also, of course, the funding. And I would like to make this announcement that we will give the title of honorary doctorate to Professor Emeritus Gregory Grigoriadis in the University of Patras in July. And this will be done within the context of a workshop that we are organizing now for the students that participate in an Erasmus Mundus joint master degree that we are running together with the University of Italy and France. So this is a chance to honor one of the founders of the liposome field, who is Greek. So thank you very much for your attention.
I was ready to say that you did not mention Grigoriadis in the first slide. You see,
yeah, I forgot.
I'm very happy.
Because I saw that you were very
Yeah, but we had a discussion in Budapest in 2019 about the COVID and the potential laureates, Nobel laureates,
yeah.
And this name was discussed at that time. Okay, so the paper is open for discussion.
It's a different field.
All clear. Thank you very much indeed, once again. The next speaker is Dr. Dimitris Fatouros from the University of Thessaloniki. He's professor in Laboratory of Pharmaceutical Technology. He graduated from the University of Patras. Actually, he's a grandkid of mine. Academically. I'm really happy, although we support different football teams. So his talk is on new strategies for buccal delivery. Yeah, using emerging technologies. Okay.
Good morning. Good morning, everybody. I'd like to thank you, Professor Macheras, for inviting me to this meeting. So, my presentation today is new strategies for buccal drug delivery using emerging technologies. Some general considerations for the buccal route of administration. It can offer a fast onset of action, and this is due to the rich blood supply in the area of the oral cavity. We have also the absence of drug degradation compared to the GI tract, where we know this is a harsh environment. Also, the absence of first hepatic past metabolism, and also we have reduced doses in the oral cavity, and that means lower toxicity. And finally, we can achieve both local or systemic therapeutic effects. Also, if we consider that we can work with very potent APIs and large molecules. So, I will go a little back to another field because actually we borrowed this technology from another route of administration. Perhaps for most of you, you are familiar with the microneedles. Microneedles are biomedical devices. They are comprised from arrays with micron-sized needles for non-invasive administration. And actually, they have been used for drugs, vaccines, and macromolecules. So what we propose is microneedles for the buccal application. That could be a promising approach for the effective treatment using peptides, proteins, but also small molecules. There are two main advantages from our aspect. The first one is that they can protect the APIs from the GI tract, and also also they could be an efficient drug delivery system for special populations, for pediatric and geriatric populations. And in the small slide, I will explain it a little bit more. So, what is the 3D printing? Actually, I guess my colleague, Professor Denis Durumis, has already explained yesterday. Additive manufacturing technologies may overcome challenges in drug formulation development by addressing the requirement of personalized therapy. So, additive manufacturing and more specifically 3D printing can allow the creation of formulations in a simple step process. I'm not going to get into details for the different techniques today. I will describe briefly the digital light processing. In this one, we have a tracer with a resin. In our case, we use a biomedical resin, and we have the photopolymerization of the resin, of this resin. It's a bottom-up process, and it built the object by layer by layer. And we used this technique because it was proved that we can fabricate microneedles with high resolution and accuracy, and as you can see, they are quite reproducible. So, in essence, what we have, you can see here that we have the CAD, and in our approach, we have the microneedles, but this time it is we have attached also a reservoir. So, we have the digital design of the hollow microneedles. This is an STL file which will be uploaded to the DLP printer. Then we print our object, and then we have the post-curing process. I said previously in my previous slide that why we are focusing to special populations. Actually, we are targeting two populations. It's the geriatric population. Swallowing difficulties are main problems for elderly people, and these are related with polypharmacy. Old people get many drugs in a daily basis, and also this is related with xerostomia, dysphagia, and of course neurological conditions. On the other hand, we're focusing also to pediatric populations, and this is because the injections are associated with fear and discomfort, not only for young people but even for older people, and that causes, let's say, pure adherence for our patients. So, briefly, the methodology, we designed the microneedles and we fabricated them. We performed visualization studies. Also, we complemented these studies with microfocus computer tomography. What information we can get from microfocus computer tomography in simple words, we can compare the nominal versus the actual size of the printed objects. Also, we moved with penetration studies using, of course, an ex vivo model by using buccal porcine mucosa, and we performed also finite element analysis. And we completed our studies with permeation studies, ex vivo, of course, histological evaluation, and cytocompatibility studies. We used TR146. This is a human squamous cell carcinoma cell line, and this is a typical cell line which can be used for buccal delivery. So, what we can see here is that we designed two types of microneedles, hexagonal microneedles to the left, and syringe-like microneedles. And you can see, of course, the microneedles with the reservoirs. Needle height, layer height, and the tip diameter are important parameters for the good dimensions of the microneedles. Before saying that, we had arrays 7x7, and our target was microneedles with 700 microns length. The objects we received after the fabrications were in good agreement with the digital design, and we also shown, and it can be seen also from the images that we had good printability. So we moved to mechanical properties with scanning electron microscopy and micro CT studies. Let's explain a little bit how we do the comprehension tests. Actually, we use a metal rod. We attach our macroneedles to this metal rod, and this starts to descend it is programmed to descend with steady speed up to a metal plate. So in that case, what we can see is that we have an exponential increase up to the point that the metal rod touches the metal plate. We use the load cell of 500 newtons, and what we can see is that hexagonal microneedles can withstand forces up to 200 newton, and the syringe like up to 310. I would like to mention here that the forces we apply to the buccal mucosa is up to 10 newtons. So that seems that we are quite far, and still these microneedles can be used for buccal application. We do it also the scanning electron microscopy studies after the compression tests, and what you can see is actually that we have fragments for the hexagonal-like microneedles, and in the case of the syringe-like, we could see some holes. Again, we performed micro-CT studies. What we saw was that we had a 6% length variation between the needles, and if we'll focus also to the fluid supply, the reservoir in simple words, what we can see is that for hexagonal-like microneedles, it was more susceptible to printing. We have some imperfections. Also, we measured the needle volume, the lumen, in simple words, of the microneedles. For the hexagonal, it was 0.17 cubic millimeters, and for the syringe-like, it was 0.184. Moving to the penetration test and finite element analysis, more or less we did the same studies like with the compression, but this time we use buccal tissue, so it was pinched to a cork plate, and again you can see the metal rod and the microneedles attached onto this metal rod, and what we can see to the figure B is that it can leave a fingerprint and the perforations of the microneedles onto the buccal tissue. The results we obtained from this test, in the y-axis we have the force. You can see we reach up to 10 Newton, and at the x-axis we have the deformation. And what we can see is a gradual increase, and at the moment we have this drop in the curve. What is the physical meaning is the moment that the microneedles attach the skin and start the perforation. So what is the home message for this graph is that the hexagonal-like microneedles can penetrate deeper and faster, and this is because they are more sharp. Also, we measured with an optical microscope the dimensions of the microneedles after this penetration test, and what we found was that there was a decrease to the height for up to 30%, and this is an indication that the needles could penetrate into the buccal mucosa. We moved to permeation studies, starting from figure A. We can see the experimental setup. We use the front cells. I guess all of us were familiar with these cells. We attached the buccal tissue, and also we have here the microneedles with the reservoir, and this is microsyringe pump, Harvard type. What we did is that we tested different flow rates. This is really important, and this is something that is usually tested during all these experiments. And according to the literature, we found that with the lowest flow rate, we achieved the highest permeation. Why this happens? If we have high flow rates, we have a leakage from the needles, so all the material is spread onto the skin, and so we don't have a uniform distribution of the active into the tissue. Once we finalized the flow rate, which was 0.5 milliliters per minute, then we decided to perform experiments with the two different compounds. We used one with low molecular weight, and these are actually model drugs, model dyes. And that was calcine with a molecular weight of some 600 Dalton and dextran. Actually, we did two protocols. In one protocol, we applied our microneedles, and we did the piercing for 30 seconds. And in the second one, we applied the microneedles for 60 seconds. What we can see is that in the case of the large molecule, we had an increase of fold compared to the control, and also the piercing time, also the structural features of the microneedles, like the lumen, the internal volume of the microneedles, or even the sharpness, seems that they don't have a significant effect to the transport rate. And we believe that the dominating factor in this case is the diffusion of the active into the tissue, which dominates and gives all these results. However, the picture was completely different when we used calcine. Actually, when we use calcine, you see that when we apply calcine, plain calcine, the permeation is almost negligible. This is normal because calcine, it's a hydrophilic molecule. Has little or no permeability through membranes, and actually it has been used also as a marker to check the membrane integrity. And what we saw is that after 60 seconds, calcine permeability was up to 1,000-fold increased compared to the control. However, if we focus to the 30 seconds, we can see that the hexagon-like needles can increase the transport. If you remember the test we did with the penetration, we can see that these needles can penetrate faster and can go deeper. So this is the reason that we can achieve higher transport. However, after 60 minutes, more or less the transport of the active is comparable. The reason for that is that also, if you remember, the penetration tests, after 60 seconds, the height of the microneedles has been already decreased. So all the phenomena are happening during the 13 seconds. We moved with biocompatibility studies, and once the permeability studies finished, we got the tissues, and we stayed with eosin hematoxylin. This is for 30 seconds and 60 seconds for the hexagonal like microneedles, and This is for the syringe-like. What we can see is that at 30 seconds we don't have any changes to the tissue. However, after 60 seconds we have a partial detachment of the upper layer, and in the second case we can see very nicely a pattern of the printing. You can see here nicely all these perforations. However, in both cases, these changes to the tissue are reversible, so the tissue can recover from the piercing. At the end, we performed some cell viability studies. As I said before, we used the typical buccal cell line, and we used our control. And what we tested was, first of all, a film. So we printed the film with our resin, and we incubated with the cells. And then also we printed the resin in cubes of 3 by 3, and we incubated with PBS, and we did the dilutions. What is the reason for that? We know that these resins are prone to itching. So in essence, we wanted to see if any monomers could pass to the medium. And at the end, of course, we used the resin as a liquid, which is the starting material, and we tested it in 2 different concentrations. Actually, what we could see is that in most cases we didn't have any toxicity. I would like to emphasize here that when we're discussing for this kind of applications, we're talking about 60 seconds. So in that case, although it is an empty team assay with all the limitations of this method, we can conclude that this material is safe, at least from toxicity issues. So, what are the conclusions? Is that the printing microneedles device with custom shapes and definitions can be fabricated. We could also include reservoirs into the microneedles. They had the appropriate mechanical properties and penetration ability into the buccal tissue, and we can deliver actives with different molecular weight. Also, the histological evaluation and cell studies confirmed the safety of the printed devices. Do I have some more time?
Say 1 minute.
No, in that case, it's not possible. Okay, so thank you very much. Just I would like to say something about visually impaired people very, very briefly. We have developed buccal patches where we have added braille reading for people that have visually impaired, because so far all this information are in the secondary packaging, pharmaceutical packaging, and this time it was the first time that we printed them on the pharmaceutical dosage forms. We did also this an in vivo haptic evaluation study, and with people with visually impaired people, and they were really very happy to have this information, not to the pharmaceutical packaging, but to the dosage form. And I would like to thank my colleagues from University of Southampton, from Hellenic University, International Hellenic University, my PhD student, and 2 former postdocs. Thank you very much for your attention.
Thank you very much indeed. Thank you, and apologize for the time pressure. Any questions from the audience, please? Yes, please. No, the lady.
I would like to, very nice work, I would like to ask you, what is the material?
It was a dental resin. These are resins that they have been used for dental applications. But yes, for dentists, yes, they stay in the mouth. But in our case, imagine that it will stay for only 60 seconds. Now we are working with monomers, and we are trying to incorporate our drugs into these monomers and start from the very beginning with the photopolymerization. Of course, it's a difficult task because these molecules are prone also to degradation due to photopolymerization. So we would like to have encapsulated these monomers to our microneedles.
So there's no chance that the microneedle will rupture or not?
Speak louder, please.
Yeah, I don't know.
Where is the lady?
There's no chance that the resin will break or
No, because actually
will not be perpendicular to the.
no, because actually, as you can see, they can withstand forces up to 210 newton. We apply only 10 newtons. So this is yes. So yes, so it's only they open small holes.
Okay, we'll have a question from Dr. Gurguis up there.
Do you think it's going to hurt?
No, for sure. We have tested unofficially to our mild because actually it's in the lab. Okay, it's not nice to say that, but usually it happens with researchers. But we are planning actually to apply to our bioethical committee to do also some of these tests. But because these are polymers, they don't cause any pain compared, for example, with the metallic microneedles.
Okay, thanks. Clive, a short question.
What you've done essentially is printing.
Yes.
So it's 30 seconds, and you've got a needle, and that's not going to spread very far from your materials that comes out. It's not going to spread very far from the tip of that needle.
Yeah.
Right. So, have you thought of trying to actually vibrate that plate?
Yes.
Now.
Yeah, that would be also a good option. Yeah. Thank you. Thank you very much.
Thank you very much, Anke. We will continue with Dr. Sen from University of Nottingham. Apologize for this, the disordering system I created. It was due to the absence of the first speaker. Okay, that's why I apologize. So the title of the talk is Target Delivery of imiquimod to mesenteric and retroperitoneal lymph models following oral administration. Please.
Okay, thank you. So first of all, I just want to say I'm not a doctor yet. I'm still a PhD student. So yeah, but thanks. I hope I will become doctor soon. So yeah, so I'm Haji Chen. I come from the University of Nottingham. And today it's my honor to present what I have done so far in my PhD project. So from the title you can see, in my PhD project, I'm aimed to target the gut-associated lymph node, which are mesenteric and retroperitoneal lymph node, with imiquimod, which is an immunomodulator, following oral administration. So let's start about the imiquimod. So this compound is a small molecule for toll-like receptor 7 agonist. It has been approved by the FDA 10 years ago for application of skin cancer and genital wall. So in the tumor progression and metastasis, the tumor cell, they will release a specific antigen, which we call tumor-associated antigen. This antigen could be detected by the antigen-presenting cell, such as dendritic cell. Those signals is going to help immature dendritic cell transfer to the mature site, which is going to further stimulate the immune response, which include activate the cytotoxic T cell to eliminate and even suppress the tumor growth and metastasis. So as for the mesenteric lymphatic system, especially in the mesenteric lymph node, they occupy more than 50% of the lymphatic system. So in this case, we think if we can deliver imiquimod, this compound, to those lymph nodes, it's going to accelerate the maturation process of the dendritic cell. As a result, it might help us to improve the cancer therapy for the cancer patient. In another hand is in the colorectal cancer patient. So this type of tumor, they're very likely to migrate to the distal organ through the lymph vessel. So in this case, if we can target the the mesenteric lymphatic system is going to help us to prevent the metastasis of this cancer as well. But now the question is, how can we target those mesenteric lymph nodes? The answer is we can take the advantage from how our body digests fat. So for most of the molecule, once they will be absorbed into the intracyte, they will go to the systematic circulation after the hepatic first-pass metabolism. However, for highly lipophilic drug, or we design a highly lipophilic prodrug for a hydrophilic drug, those molecules is going to associate with a large lipoprotein, which we call chylomicron, in the intracyte. So this lipoprotein will be greatly produced when we digest fat. If we take this lipoprotein as a carrier, because the size of this lipoprotein associates too large to be transported into the blood vessel, eventually this kind of complex will be taken to the lymphatic system and eventually release our drug in the lymph nodes. So the previous research from our lab have already proved the feasibility of this strategy. So far you can see, the key for this mesenteric lymph node targeting is chylomicron association. Actually, there are several physical-chemical properties we can apply to predict the chylomicron association at the in silico level. And also, we can use this physical-chemical property to help us to design a proper structure for the prodrug structure for imiquimod. So from the in silico prediction, you can see this has very low chance for this molecule to be associated with chylomicron. Not only at the in vitro level, what we did is we measured the percentage of this compound associated with an artificial chylomicron, which we prepare from the intralipid. Not only this, we also measure the triglyceride solubility of this compound. It is because there's another group from Monash University, the Porter's group. They suggest a good candidate for lymphatic targeting at least it should have more than 50 milligram per milliliter of the solubility in triglyceride. So that's the reason why I also measure the solubility here. So based on those in silico and in vitro data, we made our first hypothesis, which is without chemical modification, imiquimod will not be transported into mesenteric lymph node following oral administration. In order to validate our hypothesis, we studied the PK study in the SD rats. So in general speaking, the IV PK profile is good and is reasonable. However, we found something quite unusual. It is we noticed the oral PK profile of this compound is very erratic and it has huge variance among each individual animal. So actually, this PK profile might suggest there might be multiple absorption sites for this compound, which means this compound could be firstly absorbed from the lumen and also the small intestines, and then this compound can continuously be absorbed from the colon. Finally, this compound may also be absorbed from the rectum region. It kind of makes sense because you can see at the late time point, the concentration of imiquimod increased rapidly because the compound which will absorb from the rectum region will not go through the hepatic first pass metabolism. So that could be the... Sorry. Yeah.
It's a heresy. Sorry.
So yeah. So this could be the it could be one. At least is my explanation for that. So another thing I feel is quite interesting is I will notice the estimated oral bioavailability of this compound. It is less than 10%. Although from the previous document from the FDA, it reported the oral bioavailability of this compound in the rats is essentially 0. We notice actually this number is not 0, but still very limited. At this stage, we want to conduct the biodistribution study to further identify our hypothesis. Since this oral PK profile is quite erratic, there's no such a very clear Tmax for this compound. So we select the time point at 2 hours and the 28 hours as a local Tmax for this compound. So what we found is quite surprising for us. So I want to emphasize here. So in this figure, the y-axis is not the concentration of imiquimod, but it's a ratio of imiquimod concentration in the red plasma versus its concentration in the lymph node. So although imiquimod, this compound, doesn't fit any criteria as for lymphatic targeting via chylomicron association pathway, is we still notice this compound has a high concentration, a high accumulation in those mesenteric and iliac lymph nodes, which are the lymph nodes responsible for the lymph fluid drainage from the upper and lower bowel. The reason for this scenario situation and now is unclear, and we plan to investigate it in the future. So far, when I first noticed this result, I was quite panicked because kind of against my first hypothesis. So after I calmed down, I start to think, do I still need this lipophilic prodrug approach? My answer is, yes, I still need it. Because now, I not only expect this lipophilic prodrug is going to increase the lymphatic transport, but I expect this lipophilic prodrug can offer us a less erratic oral absorption. So in this case, I designed a series of the imiquimod prodrug with the unsaturated saturated fatty acid from the decanoic fatty acid to the stearic fatty acid. And I also applied their corresponding unsaturated structure to design this prodrug. So from the in silico and in vitro data, you can see those prodrug looks quite promising. They have pretty good color association and relatively good solubility in triglyceride. However, before I select any of them and bring any of this prodrug into the animal study, we want to select it wisely. Which I mean is, a good candidate in my project has to be a prodrug which has relatively good stability in the intestinal lumen and also has to be very stable in the entrance site. By contrast, I hope this prodrug could be very unstable, which means this prodrug, once it arrives the lymph nodes, is going to release the compound as soon as possible. So in this case, we applied the 3 different in vitro models to measure the stability. So first, I used the fast stage stimulate intestinal fluid, supplement with asteroids to mimic the condition in the intestinal lumen. And I also collect the brush enzyme visits from the small intestine to mimic the enzymatic condition in the enterocyte. By the end, I use the red plasma as a surrogate for the enzymatic conversion in the lymph fluid. So what we found for this prodrug is, for saturated imiquimod fatty acid prodrug, when I increase the chain length of the fatty acid, those compounds can be more significantly stable in the intestinal lumen and in the red plasma. However, if I replace this saturated structure with their corresponding unsaturated structure, it's going to help decrease the half-life significantly. So at this stage, we choose the imiquimod myristoylic acid and the imiquimod linoleic acid prodrug as a good candidate for the future. So as I said, I'm a PhD student, so my research is still going. So right before I come for this conference, I haven't finished the in vivo study with these 2 projects. So please be patient and waiting for my future update. As for conclusion, so in my project, we first noticed the oral PK profile of this compound in the rats is very erratic. And we also reported the bioavailability of this compound. It is not 0, but still very limited. And we found the funny thing is the reason for the substantial accumulation of this chemically unmodified imiquimod in lymph node is unclear, but we plan to investigate it in the future. And for the last is the highly lipophilic prodrug we synthesized looks quite promising as for lymphatic targeting. However, it is unclear if this approach will be superior to deliver the unmodified imiquimod. Here I want to warmly thanks to my supervisor team, Dr. Pavel Jadrijevic, Mike Stock, and Dong Hyun Kim, and also get great help from our lab mate. And now I'm ready for any question.
We really thank you very much, and we'll have some questions. We'll start with Clive.
I apologise for my outburst. I used to teach pharmaceutics at Nottingham, and I tried really hard to tell them that you don't get rectal absorption avoiding the first pass effect. It only happens if you've got portal hypertension. It's not a route. And the other thing about the end of the gun, it's full of shit. And that's not a great dissolution medium. The reason for your erratic absorption is probably because material is stored in enterocytes for long periods of time, and as different cues come along, the material is released. Go well away from the idea of a rocket-powered suppository.
Okay, thank you. Yeah, so yeah, you're right. So actually, in the future, we plan to measure the concentration of the imiquimod in the gastrointestinal wall. So it might answer what, prove what you said. Yeah.
Well, it'll be in the mesenteric. You'll look in the wrong place. If you look at, take a gut out, you look at the mesenteric, yeah. You'll see the fat part here. That's where you look. You don't look in the gut.
Okay, thank you. Yeah.
Always like that, with these horrible insoluble compounds that have erratic absorption. We have done some work using milk as a medium for dissolving, but we'll discuss later on about that. Okay, there is any other question, please? Okay. Okay, let's move on to the next speaker. Thank you. Professor Milena Takac is the next speaker. She is from the Faculty of Pharmacy and Biochemistry, University of Zagreb in Croatia. She gonna talk on prediction of BCS and ECCS of macrolides in new drug discovery, focus on substituted azithromycin derivatives and their conjugates.
I can't see mine.
Can you limit me? Can you limit me?
Okay. Okay. Thank you, Panos, for giving me the opportunity to deliver my results. Our group from Zagreb, entitled Prediction of BCS and ECCS of macrolides in new drug discovery, with focus on substituted azithromycin derivatives and their conjugates. I came from Zagreb University, and we are working together in a small group with I will talk about challenges in drug discovery and development, although I know that all of you know a lot about that. And I will turn on macrolide antibiotics and to azithromycin futures. Now I will focus on azolide scaffold, which is very important for this research. And I will talk something about BCS evaluation of macrolides involved in this evaluation, and ECCS evaluation. And finally, I would like to say something for conclusion. Drug discovery and development today is very challengeable for pharmaceutical industry because novel and efficacious APIs have to meet the needs of the growing and aging global population. The main challenges are that the drug discovery is expensive, time-consuming, and risky business. More than $2.5 billion need to put the new chemical entity in clinical practice. High costs are especially in clinical phases and especially in phase 2. Time-consuming new drug in clinical practice need on average 10 to 15 years. And risky business because we spend a lot of money and because of the fact that 90% of clinical drug developments fails at late stage failures, especially in phase 2. Current trends in drug discovery are related to new modalities and emerging new target spaces, which is very important because they allow the exploration of unprecedented indications, or we can address so far undruggable targets. New strategics include the design of allosteric ligands, covalent binders, other modalities, and all these design methods currently heavily rely on artificial intelligence and advanced computational methods. New targets are proteins, means receptors, enzymes, carrier proteins, structural proteins, for example, tubulin, lipids, cell membrane lipids, nucleic acid, DNA, RNA, carbohydrates related to cell surface carbohydrates, antigens, and recognition molecular. Efficacy has been shown to be related to strong genetic link to human disease. With better understanding of the target biology and the availability of biomarkers to bridge from animals to humans will improve efficacy of new chemical entities. Probably many of you are familiar with this figure in which we can see that the drug approvals and the research and development spendings over the last decades are constantly increased. You can see that still there is a small molecular increase. You can see approvals from 1992 to 2017. And also there is some increase in recent years of approved new chemical entities which are biological origin. If we can, these two lines, we can observe that the billion USD dollars spent for research and development per year is really increased, and much more than percentage of sales spent for research and development per year. So this is a big problem. The problem in drug research and development is drug failure. In the 1990s, drug failure was related to pharmacokinetic properties, and pharmacokinetic properties were often causing clinical drug failure. Nowadays, late-stage attrition is usually attributed to the lack of efficacy or to compound-related safety issue because of maybe strict requirements of agency like FDA or EMA. Safety can be improved by ligand optimization, which is becoming increasingly in demand for difficult targets. Ascribing single reasons for compound failure could be an oversimplification because there may be multiple factors contributing to the decision to terminate the development of compound, not only PK parameters, efficacy, safety, money, so all these facts can reflect on termination of the drug. The process of drug discovery and development and the failure rate are different at each step of drug discovery and development. For example, in the phase of target validation, disease model, target identification, target validation can be the reason for failure. In compound screening, visual screening, HTS, in the phase of preclinical tests and lead optimization, structure-activity relationships, drug-like properties, solubility, permeability, unmet properties, plasma PK, efficacy, toxicity. And in phase 1 and phase 2 and 3, PK, dose efficacy, toxicity, toxicity are the main reasons for termination of drug. Poor solubility reflects to low bioavailability. During early stage of development, innovators often focus on potency or efficacy for candidate selection, which reflects to that solubility bioavailability considerations are often overlooked. This oversight can lead to time and effort being spent on overcoming developability deficiencies of a compound, and the time to market is increased due to that. Recently, there have many technological advances in solubility improvement. Poor soluble drug is a big problem in its development, and still it is a challenge for pharmaceutical industry. On the bottom of this slide, you can see the strong requirements of experts from pharma industry that they advise us that if non-developable, terminate molecule as soon as possible, because in that case we save our money. Now I turn to macrolide antibiotics. Probably all of you know a lot of them. They are inhibitors of protein synthesis with broad spectrum of activities, and they are very important for clinical practice, and they are often used. The elementary component of macrolide antibiotics is this big macrolide ring system with 12, 14, or 15 or 16 carbon atoms, which is also combined with deoxy sugar on position 3, or with amino sugar at position 5. So far, all macrolide antibiotics that are in clinical practice are derived from erythromycin, such as clarithromycin, azithromycin, telithromycin, and also there are 2 new drugs which are in phase of clinical studies, carbamazepine and azithromycin. Azithromycin has been synthesized from erythromycin A in 4 steps in synthesis, and it is the first member of the azolide class, means that in this macrolide ring system, nitrogen atom has been introduced, and after that it was methylated. This drug is, according to its biological activity, it inhibits protein synthesis as all other macrolide antibiotics by reversible binding to 23S RNA on the 50S subunit of the ribosome. While we are working on azithromycin, which was first registered as cenobamate or azithromycin in the rest part of the world, because it is the most important pharmaceutical product ever produced in Croatia. So I'm a little bit sentimental because of that, and I have to mention that. It was discovered by Pliva research team in Zagreb in 1980s and registered in 1988. With this discovery, Croatia became one of the 9 countries in the world with original antibiotic. Currently, it is on WHO list of essential medicines, and in 2020, it was 68 the most commonly prescribed medicines in the United States. I have to mention here the main researcher, lady Gabriela Kobrehel, and its a project leader, Slobodan Đokic. They are main researchers in this small team with this Gorjana Lazarevsky and Zrinka Tamburashev. And first 2 researchers in 2000 were awarded with the Heroes of Chemistry by the American Chemical Society in Washington. So this is that award. What can we say about azithromycin comparing to other macrolides? Azithromycin is azolide, as I explained before, due to nitrogen atom in a big macrolide ring system. It possesses broad spectrum of activity. It covers all relevant bacteria causing respiratory tract infections, including Haemophilus influenza. And it is with unusual pharmacokinetics, meaning that it possesses high tissue distribution and metabolic stability and high tolerability. However, the major drawback of azithromycin is poor solubility in aqueous environments, which impairs its absorption and ultimately bioavailability. Comparing with erythromycin and clarithromycin, 37% of azithromycin possess bioavailability, while erythromycin was 25% and clarithromycin is a little bit better, 55%. All these properties led to widespread use as azolide scaffold for synthesis of new compounds with more favorable pharmacokinetics, and not only as antibacterials, but as anti-inflammatory and immunomodulatory activity, and some macrolides have shown tuberculostatic, antimalarial, antiviral, and anti-tumor activities. To increase these activities, azolide scaffolds were combined with compounds with the desired action to form new complexes or conjugates with improved bioavailability. Main positions of azithromycin molecule, you can see on this structure, it's at position 2 on this methyl group, which can be hydroxylated. So we obtained hydroxy methyl group. Also changes can be obtained on this position where we have the oxy sugar in position of 4 and para position of this sugar moiety, or we can remove the complete deoxy sugar from that position. Also, changes or modification can be made on this position 5 with this amino sugar, at position 3 with 2 with changes this hydroxyl group by oxidation to carbonyl group at position 6. But the most changes of this drug were made on this nitrogen atom involved in the macrolide ring system. On this position 9,8, they have synthesized a lot of conjugates which improve pharmacokinetic properties of the drug. We use the biopharmaceutical classification systems, although it is very important for maybe development of drugs which is approved, but there is no reason why we not, when we have some in silico methods and good softwares for prediction of BCS properties, to evaluate all molecules, not only macrolides, for the BCS classification. With this system, within this framework of human pharmaceuticals, drug can be classified into the 4 of BCS categories from class 1 to class 4. And this strategy or this idea was first published by Amidon and co-workers, and also Jednačak, who is present here, was co-worker in this theoretical basis for biopharmaceutical drug classification. Basically, although many of you are informed and familiar with this BCS system, is with these four group. Class 1 is characterized by high solubility, high permeability, while class 2 with low solubility, high permeability, and class 3 with high solubility and low permeability, and class 4 low solubility, low permeability. We use in vitro permeability properties and the volume required for dissolve the highest doses to prepare this or evaluate this biopharmaceutical classification system, or very often when we have a lot of molecules, we use in silico methods to evaluate that, which we make with our molecules and our macrolides. So we didn't evaluate biopharmaceutical drug disposition classification system, but I have to mention this complementary classification system, BDDCS, which was proposed by Wu and Bennett in 2005, because Professor Bennett is here, so thanks. When I prepared this presentation, I saw so many publications with you and your co-workers from the very beginning. You recognize that the drug exhibiting high permeability and are generally extensively metabolized, while poorly permeable compounds are primarily eliminated as unchanged drug in the bile and urine. BDDCS has been used to predict drug disposition and potential drug-drug interactions in the intestine and the liver, and potentially the kidney and brain. Panos and his co-workers in detail explain the similarity and the differences between these two approaches. So in BCS and BDDCS, the solubility is the same, but in BCS we use permeability, while in BDDCS we use metabolism. So this presentation deserves a lot of time, so I will not spend any more time here. I would like to show BC plots for 1, 2, 3, and 310 macrolides based on permeability, effective permeability, and water solubility, intrinsic water solubility obtained using ADMET predictor TM of Simulation Plus. As you can see, there are not too big differences among all 300 molecules, although changes and substituents at different positions and their combination are pretty different here. We have here only a few molecules which are out of the rest of part of molecules which are on the borderline of these classification fields. Predicted BCS classes of more than 300 macrolides based on permeability and water solubility. You can see here the majority of the drugs, especially in doses of 5 and 50 milligrams, belong or are classified in BCS class 3, while the biggest part of macrolides in doses of 500 milligrams are classified in class 4. This represents a big problem in drug development for such kind of macrolides. Here on this slide you can see structures and the predicted BCS classes of these unusual or a little bit different macrolide compounds and their position in this BCS classification, comparing with azithromycin molecule. Here azithromycin third in the middle of the group of these macrolides. On this table, I summarized the most important and relevant information for these macrolides of the admit risk, which is from 3.5 to maybe to 5. Absolute absorption risk was predicted among between 5 and maybe 10. And absorption code for all these risks are in very often situations is a size, number of hydrogen bond and hydrogen bond acceptors, charge, and also permeability, which was used in creation of that plots for BCS. Many of drugs waived the rule 5. It was because of molecular weight, number of nitrogen and oxygen atoms. Lipophilicity is relatively low, and the solubility is also okay for this drug. So, according to this evaluation, you can see that for the azithromycin, it fell completely in class 3 of this system. For example, molecular 25th A and 25th B are classified in two class of BCS system, and the rest of molecular is more or less similar. Now we turn to extended clearance classification system, which was introduced by Varma et al. In 2015, which is this system is useful for yearly prediction of predominant clearance mechanisms, rate determining process related to metabolism, hepatic uptake, or arena. Based on physicochemical properties such as molecular weight, ionization, pKa, and passive membrane permeability. In this case, it was used MDCK. This scientific framework facilitates risk assessment of the pharmacokinetic variability associated with drug interactions and pharmacogenomics. It is limited to small molecules for ionization or acids, sweeter ions, and basis neutrals. It is recommended to use MOKA to predict the pKa at pH 7.0. MDCK permeability was used either experimental or data or predicted data. According to this ECCS system, we can classify our molecules in 6 classes: 1A, 1B, 2, 3A, 3B, and 4. And this scheme was applied to 300 compounds. It was correctly predicted in about 90%. I will not talk because Panos is here, so it means that I am...
I'm contemplating.
Okay. 6 classes for class 1, metabolism as primary systemic clearance mechanism. It's related with high permeability acid sweeter ions with molecular weight below 400 Daltons in class 1b. Transporter-mediated hepatic uptake as primary systemic clearance mechanism. High permeability acids sweeter ions with molecular weight over 400 Daltons. Class 2 is characterized with metabolism as primary clearance mechanism, high permeability base neutrals. At class 3A, renal cleaners, low permeability acids, sweeter ions, and so on, below 400 Daltons. And in class 3B, transporter-mediated hepatic uptake or renal clearance, low permeability acids, sweeter ions, with molecular weight over 400 Daltons. And finally, in class 4 is characteristic as renal cleaners, clearance for drugs with low permeability and bases or neutrals. Results of the ECC evaluation of these macrolide molecules, you can see average results of average evaluation. More than 80% of macrolides are classified into class 4, about 90% at the class 3B, and less than 1% to class 2 out of all studied molecules. In conclusion, we can say after this evaluation that only 28, meaning 7.35% and 20 to 7.10% macrolides at all 3 doses were predicted for BCCS class 3 and class 4 respectively. The BCCS class 4 was predominantly predicted for macrolides at doses of 500 milligrams, around 70%, by only for 23, 41%, and 5.6% of 50 milligrams and 5 milligrams respectively. According to the evaluation results of the ECCS, the hepatic uptake were predicted as the main clearance mechanisms for the majority of studied macromolecules. Thus, 80% of macrolides were assigned to the class 4 with hepatic uptake of 67 and metabolism of 23, 79%. By only 90.03% of macrolides were assigned to ECCS class 3B, of which 77, almost 80%, were classified with hepatic uptake and 2.03 with metabolism as the main clearance mechanisms. In conclusion of all these evaluation, we can say that regardless of the introduced modification in the chemical structure, most of the derivatives with azylide scaffold have properties similar to azithromycin. So maybe we need to if some molecule or some candidate will be promising among these new molecules, we need to use maybe the same system to increase its solubility in water environment. Thank you for your attention, and I have to apologize to my co-chair because I overlooked that the time zone in Zagreb is different from the time zone in Athens, and I think that it is that I have enough time that I need not to be 1 hour earlier. Thank you very much for your attention once again.
You are always most welcome, Milena.
Thank you.
Okay. So first of all, I would like to thank you for mentioning my work. And I take the liberty to clarify what I have contributed to the BCS. And this should be clear. We always think in terms of solubility dose ratio. Okay, we always is soluble, but how is the dose? So I suggested that we should use solubility dose ratio for classification purposes, not for a static reason, but for a dynamic reason. The rate of dissolution is important in terms of the solubility dose ratio. In fact, the mean dissolution time
depends on the dose, it's not independent. We all of us, we utilize the classical concept that the mean resolution time is equal to the reciprocal of the rate constant. This applies only in one case, when the dose is equal to the dose needed to saturate the medium. This is correct. In all other cases, is wrong. I don't use solubility dose ratio for, say, static reasons. There is a dynamic reason behind. Since the basic property, the dissolution rate, depends on the dose. And this has been proved clearly mathematically for all cases, depending on the dose we use. This is a basic paper. I received only 200 citations for this, but at this very moment, it is not appreciated in the pharmaceutical sciences, the basic reason, which is the dynamic reason. Okay, I really thank you for mentioning my work. So the paper is now open for discussion.
I must say that it was very useful because I'm a medicinal chemist. I'm not a pharmacokinetic researcher. So when you are enter into new field, but I start with this group to evaluate maybe metabolic predictions and so on, and this it's really very useful because you and your co-workers explain in details what the beginner have to know about that. Thank you very much.
I also use this Cartesian way.
Yeah.
I use always class 1 on the right hand corner, since high solubility and high solubility should be at the right high corner. This is mathematics, classical, second year in high school. Okay.
Whether you write it in Hebrew or in English.
Right.
Please. Whether you write this class in Hebrew or in English.
Please go ahead.
Question.
Yes, please.
Did I understand correctly that none of your 28 derivatives was better than azithromycin? Or you have one that you would pick as a potential follow-up compound to azithromycin?
The majority of evaluated macrolide molecules was quite similar to azithromycin. So we concluded that changes in chemical structure with changing substituents at each positions does not contribute to these biopharmaceutics classifications a lot. So maybe we need to use another approach if we find a good molecular with strong bioavailability fitting better to biological target. We need to maybe use other.
Once it's a class 4,
yeah,
a kind of no going.
Yeah, I know that. Yeah.
So,
but
as
for
a medicinal chemist, any chances? How do you take out these derivatives from class 4, class 1, or class 2?
Maybe we need to improve its permeability at first place, changing with the lipophilic substituent who will contribute that. That will improve maybe permeability through the membrane. And of course, all these in silico results we need to test it in vitro environment. So this is a lot of a huge number of molecules. So it is not possible to in vitro spend so many time. And so because we are at the very beginning of our, I must say here that molecules which are conjugates, in fact, on position 9A. On nitrogen atom with some thiosamine carbozones, and the carbozones are promising molecule for different target and not only for that. And we are currently working on that. So we are improving the pharmacokinetics profile of this molecule and changing the rest part of the macrolide ring system in order to protect the broken or hydrolysis of lactone ring, because it is essential for biological. Yeah.
Thank you and good luck with your stuff.
Thank you. Yes, please.
Okay, try to shout. It's a super idiotic question. It's very related to the topic of your lecture. It doesn't work. Which is super vaguely connected with the topic of your lecture, but I've seen pretty much every number how much have really new drug costs. I has everything from 1 billion to 2.5 billion, billion here, billion there, who cares? How much do we have to pay for a new drug? Look at luminaries, pharmaceutical, it doesn't work.
You can come here and put your question.
How much really a new drug?
It depends from drug to drug. It depends from, of course, that new protein drugs used in modern therapy are much more expensive, while small molecules is a little bit cheaper. But I think, and I do believe really that if we use during the discovery phase, not in clinical phase, in development phase, when we are creating a better candidate for clinical testing. If we use all these available softwares and these possibilities, we can maybe reduce our cost and maybe turn our research to better way till the end. To better molecules, and it is not so expensive. We can, if we in Croatia can use that possibilities, I think that pharma industry has enough money to apply all this research, and I do hope so that they do that in their everyday practice. Okay.
Okay, but is anyone aware of a scientifically sound methodology that allows quantifying the cost of a new drug in average? The developer. Yeah.
There are a lot of information, but as I can see, all financial issues are around $2 billion US dollars.
We are throwing those numbers like 1 billion, 2 billion. It's a huge difference. Come on. Like you said, oil availability at 10% or 90%, whatever. Anyway.
Thank you.
Please.
Laughter. I mean, you have this fluctuating red line, which said it's about 10% of the developing.
Can you pick up the mic? So hopefully it will.
Yeah. So showing that the developing costs are constant at about 10% of what comes in. Wait a minute.
Sorry.
So it's about 10%. I missed one line. It's also fluctuating, but it's also constant.
Yeah.
It's 30% is for marketing. So this is hello to the pharmaceutical industry. 30%. It's 3 times what they spend for developing new drugs goes into marketing. We are the good boys, so I doubt it.
Yeah. As I can say as an answer to your point of view, I pick up this graph from literature, so I was afraid to change anything because it was recent from that. It depends on authors of this paper. And I also was wondering, because it seems that pharma industry does not invest too much maybe in new drug entity and new chemicals, but they are much more oriented, as you told, towards market and earning the money, which is also normal. But the costs are increasing constantly, and there is a big gap between investment and costs at the end.
Okay. So if it is fluctuating, it might be at steady state. That means that the expenses, are proportional to the other expenses, and then they keep it, they perturb the system to remain. Okay.
The most expensive part is the phase 3 clinical trial.
Yeah, it is the most expensive. Yes.
So the problem there, to answer this is, number one, how you maximize your chances for success to show superiority over any comparator of placebo in your phase 3 clinical, because that's the major, that's at least, I think, $500 million. And the cases here, by choosing, the inclusion criteria you take, you never take the most severe patients, always it's a mild to moderate patient. That's the one, whether it's Alzheimer's, epilepsy, depression, you name it. Yet, you have to take patients that are not, in my case, seizure-free. They have to have seizure, and you have to have them at least not once a year, because then the study will be too long. They should have 10 or 15 per week, so you can complete your maintenance of steady-state phase within a month or so. And then it's still, I think, the cost per patient in phase 3, at least in epilepsy, is about 5,000 or 5,000 euros per patient.
Thank you very much for helping in clarification.
It's a unique example, this one. I mean, it's a difficult story with epilepsy. Anyway, any other question, please? So, we'll have a break then. We'll reconvene at
15 minutes.
Yeah, 12 o'clock. Okay?
Very fast.
Okay.
Do we exceed our time? Thank you very much for your attention.
Okay, so we move now to the fourth session. The first speaker is Professor Demetrios. Professor Demetrios is in the Faculty of Pharmacy at the University of Athens. A student of ours at early 80s. And he is going to speak on the complex nanosystems and health sciences. He's working in the area, and we are ready to hear him about his work in the area. Thank you.
Okay. Thank you very much for the short introduction. I'm Professor Kostas Demetrios, and I'm very happy to participate in this Congress. So I would like to thank the organizers for inviting me to give a lecture on complex nanosystems and health sciences. I will focus on pharmaceutical nanotechnology, which is a field of my expertise. And I have to point out that I'm not expert on complexity and on complex systems, but I realize that drug delivery nanosystems belong to complex systems, so it should be studied under the lens of complexity and of nonlinear dynamics. So I will start with prefix nano. Nano is a unit prefix, meaning 1 billionth, and according to Professor Gregoriadis, who wrote the introduction part of my book entitled Pharmaceutical Nanotechnology, Fundamentals of Practical Application, published by Springer, nano in Greek means door. And I will move on with a short introduction on the nanotechnology and nanomedicine. Nanotechnology is engineering and manufacturing of materials at the atomic and molecular scale. It refers to structure in 1 to 100 nanometer size in at least one dimension. The application of nanotechnology for treatment, diagnosis, monitoring, and control of biological systems is referred to nanomedicine. Here we can see an image on, regarding the scale of particles. You can see carbon nanotubes and the virus belong to nanostructures, red blood cells to microscopic scale, and diameter of human hair and average 4-year-old child to the scale of macro scale. We live in complex times, and Stephen Hawking has called this century the century of complexity. In 2021, 3 scientists received the Nobel Prize in Physics for groundbreaking contributions to our understanding of complex physical systems. And in 2022, European Academy of Sciences and Arts organized a conference on causality and complexity. The questions that have been raised are: how shall we define a complex system? What is the relation between emergence and complexity? And how shall we identify causal relationships in complex systems? Although the first 2 questions have received a great deal of attention in science and philosophy, the relationship between causation and complexity remains to be understood. A complex system contains many interdependent constituents which interact non-linearly. It's a system with numerous components and their connections and interdependencies which are difficult to describe, to understand, to predict, to manage, and or to change. And I will share with you the main difference between complexity and complex system and complicated system. For example, a car engine is composed of materials that can't self-assemble. On the other hand, an ant colony is composed of individuals that can self-assemble, and the self-assembly process is the driving force for producing complex and functional structures depending on the environmental conditions. However, the self-assembly is a great undiscovered principle of nature, and I will share with you a short video. Here you can see the main components of our cell membranes, which are phospholipids. They are composed of a polar head group and a hydrophobic tail. By mixing these molecules into an aqueous space, they come close and produce lipid bilayers. These lipid bilayers can construct nanoparticles like liposomes or lipid nanoparticles or whatever, and can accommodate hydrophobic molecules or hydrophilic molecules to an interior aqueous core. In order to understand and to show how the complexity of the system is impacted by the complexity of the environment, 3 layers of complexity are defined. The first one is the internal complexity, which is the complexity of the system itself. The external complexity, meaning the environmental conditions that can change the complexity and interact with the internal complexity of the system. And the final is the interface complexity, which is defined at the interface of the system and its environment. There are very nice tools that we can use in order to quantify the complexity, but in my view, the most important are the thermodynamic entropy, entropy von Neumann regarding quantum entropy, entropy Shannon regarding information entropy. And here is a nanoparticle composed of amphiphilic molecules, mainly phospholipids, that can self-assemble and produce lipid bilayer, producing also complex nanostructures that are able to incorporate bioactive molecules. And you can see here the interaction between a drug, say, with the surface of this nanoparticle. And we can see abnormalities on the surface of such interaction. I will share with you in the next slide the interactions which can be used in order to produce information hubs. Here is an image has been taken from my lab in collaboration with Maria Hutulesi and other colleagues. It's a complex artificial biostructure, bio-nanostructure, belonging to the class of liquid crystals. And we can see the long-range order, meaning the surface of such nanoparticles, and the internal morphology, which is composed of channels. So we can see that all these structures are not similar, and there is a complexity not only on the surface of such nanostructures, but also in the internal morphological characteristics. And here is another nano platform for drug delivery. It's composed of glycerol monolate and oleic acid, and we used pluronic as stabilizer, and you can see the long-range order, the external morphology and the internal morphology that can accommodate bioactive molecules and transport them to the target tissues. And another cryo-temp figure of lipid nanoparticles that can deliver an mRNA or genetic material. These nanoparticles have been used in order to produce vaccines against SARS-CoV-2. And we published a review article with my colleague Tsakiri Maria, and we can see that the morphological characteristics depend on the nature of biomaterials that have been used. In my view, the most important thing of such nanoparticulate system is the internal complexity and the morphology of such bio or artificial nanostructures. Here you can see in the slide 3 cubes, meaning that we have the same long-range order. But looking carefully inside, we can see 3 different morphologies, meaning that the internal morphology is absolutely different. This difference in the internal morphology can affect the encapsulation efficiency of the drug, can affect also the stability of the particle and the release profile, meaning the pharmacokinetic properties of the encapsulated molecule. And here is another important published paper entitled Self-Assembled Multi-Compartment Liquid Crystalline Lipid Carriers for Protein, Peptide, and Nucleic Acid Delivery. And what you can see here, you can see in the image X-ray scattering and high-resolution fractional electron microscopy in order to study the morphology and the dynamic topological transitions of this nanostructured multi-component amphiphilic assemblies. We can see by using SAX and Frisch fractional electron microscopy of lipid cubic lattices, you can see differences regarding the channels incorporating water. And there are 3 different peaks. Each peak corresponds to different internal morphology of such particles. However, by using X-ray diffraction, scans and other techniques like electron microscopy allow to detect metastable, intermediate, and coexisting structures. This is very important, and the question is, what is a complex metastable phase? A complex metastable phase is a particular portion or a raft of a cell or an artificial membrane. And here you can see a conventional, let's say, organization of phospholipids producing a lipid bilayer, but you can see another organization between this structure. This portion named as raft or metastable phase. However, by using fluorescent microscopy images that I showed you, we can see crystalline in red and liquid in blue metastable phases. These red and blue are metastable phases coexist in a non-equilibrium thermodynamic state. So, in my view, the thermodynamics is a very important tool that should be used in order to identify metastable phases or abnormalities on the surface of such nanostructures. So here you can see 3 different peaks, each one corresponds to different metastable phases to a different raft. And from my lab, we have published a huge amount of publications regarding thermodynamics of nanoparticulate system, and you can see here thermogram of complex metastable phases, and for example, a nanoparticle which is composed of DOPC, dioleic phosphatidyl halide, and you can see the red line which corresponds to this composition. And by adding different concentrations of polymer, PAM, PAMAM, we can see changes regarding the metastability process and the metastable phases of such nanoparticles. And other publications from my lab, we can see complex systems regarding artificial cell membranes, and you can see the peaks that correspond to metastable phases. These metastable phases or lipid rafts could be characterized as information hubs and could be used in the future for therapeutic purposes or to identify biophysical disease factors. However, the metastable phases of lipidic-based nanomedicines are considered as complex thermodynamic epitopes that should be studied under the lens of nanothermodynamics. And what is, how shall you define what is a complex thermodynamic epitope? A complex thermodynamic epitope is not a bioepitope. It represents the thermotropic behavior of a real biological epitope, and it is considered as a very complex dynamic nanораft far from the equilibrium state. So, by mapping the thermotropic behavior, thermodynamic variables of a real biological epitope, we have the ability to produce an artificial biological epitope which is named as thermodynamic epitope. And here is a short video. I have published a paper entitled Nano-Platforms as Information Carriers and Thermodynamic Epitopes in Neuro and Immune Diseases in the Handbook of Computational Neurodegeneration. And you can see here a nano-platform which can carry thermodynamic epitopes mapped by red spots and can interact with real biological epitope on the surface of cell membrane in order to interrupt a biological cascade or for therapeutic purposes. However, complex metastable phases exist in innovative nanodrugs delivery system and considered as complex events in a non-equilibrium state, reproducing the complex metastable phases of living cells can construct thermodynamic epitopes. And I will move on to the next part of my talk regarding the complexity and pharmaceutical nanotechnology. Here are well-known nanosystems like liposomes, polymeric micelle dendrimers that are able to transport bioactive molecules, or some others like gold nanoparticles, magnetic nanoparticles for diagnosis and whatever. And you can see the advantages of such nanosystems. They can increase the solubility in water of the encapsulated system, increase the targeting process, or are biocompatible and biodegradable. They can reduce the toxicity and they can control the release of the encapsulated drug, manage the thermodynamics. So the question that have been raised is the complexity and the metastability effect of nanoparticulate system the barrier for their reproducibility? And is this the reason that we have nanosimilar therapeutic products? I will share with you 2-3 well-known examples regarding complex nanosystems in health science, meaning that all this I will show you are already in market for many years. Calyx and Myoset are well-known anti-cancer medicines. They are composed of liposomes and encapsulating Doxorubicin, and Ambisome is a well-known antifungal medicine which incorporates amphotericin B, a toxic antibiotic. But it is obvious that SARS-CoV-2, the well-known virus, has a complex surface properties due to the different type of proteins that the most important between all of this is the spike protein which interact with our ACE2 receptors on our cell surface and promote disease. So SARS-CoV-2 is obvious that is a complex system. And recently you have published in the proceedings of the European Academy of Science and Arts a paper regarding the complexity evolution of viruses, and I will state that SARS-CoV-2 belongs to complex system, and its evolution and mutation must be observed under the lens of the non-linearity, as they are far from the equilibrium conditions. This perspective article deals with our argument that infectious ability of the new virus can correlate with its thermodynamic payload. We suggest that by identifying the thermodynamic contents biophysical profile of viruses protein using mathematical framework of non-linear complex system, we can simulate its molecular origin, design weapons for fighting. And it is obvious that without all these lipid cells, meaning liposomes, lipid nanoparticles or other, there would be no mRNA vaccines for COVID-19. And it is obvious, of course, that pharmaceutical nanotechnology is an excellent scientific field for developing such innovative nanoplatforms. And moving to the end of my talk, I will state that art and beauty at nanoscale is obvious, and in my view, most of novel bio-nanomaterials, nanostructures, are art rather than smart, and this because they generally and highly complex formulation, difficult to synthesize and scale up in a controllable and reproducing manner. In Gustav Menger was a German artist and political activist who developed the concept of autodestructive art and art strike, and he initiated the destruction in art symposium in 1966. You can see paintings that are composed of liquid crystals, nanoparticles, in liquid crystalline state of matter, and by changing the external environmental conditions in a liquid crystal painting, the interface complexity between the environment and the internal complexity of liquid crystal is the driving force for the final art outcome. So here is another imaginary landscape of beauty and complexity based on dendritic nanostructure. Dendrimers are belonging to the class of fourth generation of polymers, and this nanostructure by artist Angela Fragu is an amazing imaginary landscape. And I would like to promote my final book, which has been published by Lambert Academic Publishing 22, and deals with conversation between the physical and biological laws in microcosmos and macrocosmos, and presents the interfacial phenomena between the complex micro, macro, and megacosmos that we are living. I'm happy to announce that my book is was published, was translated in 7 international languages, and I'm very happy for this achievement, and I would like to thank you very much for your kind attention.
Thank you, Professor Demetrios, for the nice presentation. The floor is open to questions. A couple of questions, please. Thank you. No questions. I guess I have to proceed.
Okay, thank you very much. Thank you very much for your kind attention, for invitation, Professor Macheras. Thank you.
Thank you very much. We will proceed with our next speaker, who is Associate Professor Prokopis Mayatis. He is from the Faculty of Pharmacy from the National and Kapodistrian University of Athens in Greece, from Department of Pharmacy, and the title of his presentation is From Chemical Structure to Pharmacology and Regulatory Aspects of cannabinoids, from chemical structure to pharmacology and regulatory aspects of their use. Professor Mayatis.
Thank you. First of all, I would like to thank Professor Macheras for inviting me here today and to talk about cannabinoids. And actually, when I was finishing my undergraduate studies in 1994 in the School of Pharmacy, University of Athens, I could never imagine that one day I would talk in a scientific congress about cannabis. Well, actually, at that time and until relatively recently, cannabis was an illegal drug. So research on cannabis was also illegal. And everybody who was talking about cannabis was, let's say, somebody who is in, let's say, not very well respected in the field of science. Anyway, today everything has changed. We can find cannabis products everywhere. And when I say everywhere, I mean really everywhere. In the pharmacy stores, in the supermarkets, in special shops. It's a little bit different in each country, but you can find all type of cannabis products. And this is not something simple, because cannabis is a very, very important drug. It comes from a very important plant, first of all. And the ingredients that are found in cannabis have very, very strong pharmacological properties. It's not something simple to use this type of active ingredients without taking care of exactly how we should do it. First, I would like to say a few things about the botanic background of this plant of cannabis. And the origin of cannabis is considered to be the Central and Southwest Asia, and more specifically, the plant is native to India, Bangladesh, Pakistan. And there is a dispute about the scientists in the field of botany, if it is one species or more species. The most accepted opinion at this time is that cannabis is one species, the cannabis sativa, with 3 different subspecies. We can see the differences here in this photo. But alternatively, it is considered that there are 3 separate species: the cannabis sativa, cannabis indica, and cannabis ruderalis. Both cases are meaning almost the same thing for them, for the way of use, because the most important thing is the inflorescences of the plant. Mainly the female inflorescences of specific type of cannabis are covered with glandular hairs which secrete the resin of the plant, which is the main component of hashish. But now we hear people talking about hemp or people talking about medical cannabis. What is the actual difference? Typically, when we are talking about hemp, we mean the cannabis sativa species with the industrial use, which has very low content in THC, tetrahydrocannabinol, and high content in CBD, cannabidiol. At this point, we should emphasize that THC is the psychoactive ingredient of cannabis, while CBD has no psychoactive activities. So the plants that contain CBD and not THC are considered as the industrial hemp. And in contrast, the plants that are producing high amounts of CBD and lower amounts, high amounts of THC and lower amounts of CBD, meaning the plants that have the psychoactive activities, are considered as the source of cannabis indica. So based on this difference, we can clarify in our minds what are the differences between the 2 main types of cannabis. But going back to history, I would say that there are indications that the people were using cannabis for more than 12,000 years ago. They were mainly growing the plants for the fibers. But after that, there are written documents, there are documents in Chinese pharmacopoeia that are talking 3,000 years BC, talking about the pharmacological properties of cannabis, and specifically about the influences of the plant. But also we have other mentions and uses about inflammation, about depression, about fatigue, about rheumatism, and several other applications. Later, we have also mentions in Indian books talking about cannabis, talking about psychostimulant, sedative, and memory tonic activities of this plant. Also, we have mentions in the Assyrian sources, and also we have papyrus talking about the use of cannabis in ancient Egypt. Of course, we have also mentions in the Hellenistic period. The ancient Greeks and the Romans were talking about the use of cannabis in the treatment of pain. And this is exciting when you're looking at these so nice pictures coming from the book of Dioscorides, talking about cannabis, or also from the ancient Egyptians, talking about the medicinal properties of this unique plant. After that, the plant was continued to be used, but it was mainly introduced back to Europe in the 19th century by a British physician who was talking about the activities of cannabis after his trip to India. And then he came back to Britain and was talking about the use of cannabis in epilepsy. And this is very important because today the mainly recognized use of this plant is for the treatment of epilepsy in children. But after that, the people were started using cannabis more and more and more, but the people started to realize that the use of cannabis was also dangerous. And in the 1930s, in the United States, there was a rumor that cannabis is responsible for many crimes. So somehow it was demonized. And actually, a little bit later, it was prohibited. In Greece, we have already a Greek law since the 1920 that the cannabis use, the cannabis indica use, was prohibited and was illegal. But later, how the science proceeded, and we have in the 1940s, we had the discovery of the CBD structure, and also we have the discovery of the THC structure. But in the 70s, the cannabis was categorized as category 1 narcotics, and extensive research of the plant was banned and declared an unacceptable medical use. In parallel, in the 1988, we had the discovery of the cannabinoid receptor, the first cannabinoid, the CB1 receptor, and then the natural agonist, the anandamide. And in 2012, we had the first clinical studies on the effects of CBD. So we have somehow a dispute between legislation and science, and in this way we arrived to today, where today we have more than 500 clinical studies on cannabinoids and their receptors. We have numerous products that have been approved in several countries. And also, we have two products that have been pharmaceutical products that have been recognized from the European Medicines Agency, from the EMA. One is the Epidiolex, which contains only cannabidiol, CBD, which is used for the treatment of seizures, specific type of seizures in combination with other drugs. And also we have Sativex, which is a combination between THC and CBD, which is used for the treatment of spasticity and neuropathic pain in multiple sclerosis. So cannabis today is in the pharmacy. It's officially in the pharmacy, and not only in Europe, but also in several other countries. You can see different pharmaceutical products with different commercial names that have been approved in several countries. From the scientific point of view, if we talk about the word cannabis in Scopus, you will see thousands, really thousands of publications that have appeared in the last years. And also, as you can see here, if you search the Scopus for the word cannabinoids, you will find 38,000 articles. And most of them are mainly related to medicine and pharmacology. And it means that there is a huge, really huge interest of the scientific community on the bioactivities of the ingredients of cannabis. Of course, we know that the active ingredients are CBD or THC, but these compounds are found in the plant in very, very minor concentrations. Actually, they are found in the carboxylated form. Here is the figure showing the biosynthesis of these compounds and how they are synthesized in the plant. But the majority of those cannabinoids have a carboxyl group. During the extraction and the process of the plant, we have a decarboxylation of the natural phytocannabinoids, and we're obtaining all those different types of cannabinoids which are neutral without the carboxyl group. And these ingredients are the form of the compound that can be absorbed either orally or after vaping. And of course, the most important is the THC and the CBD, but also we have other compounds that we can now find in commercial products like CBN, cannabinol, or CBG, cannabigerol, and also CBC, and also some other minor compounds. All these compounds have the exert their activity on the endocannabinoid system. The cannabinoid system mainly has two types of receptors, the CB1 and the CB2 receptor. The CB1 is mainly found in the brain, and this is the receptor mainly related with psychoactive activity. And also we have the CB2 receptor, which is found outside of the brain in different organs. And we have different types of functions related to eating disorders, sleep disorders, neuropathic pain, effects on cancer growth, and also reduction of epilepsy symptoms. For this type of activities are also related with the endogenous ligands, which is mainly anandamide and also a few other compounds, which are naturally found in our body and have their activity through the cannabinoid receptors. So the cannabinoids have several different types of activity. You can see anti-cancer, anti-inflammatory, analgesic, anxiolytic, immunodepressive, antipsoriatic, antimicrobial, and different others. And the main compounds that are used without psychoactive activity are cannabidiol, cannabigerol, and cannabinol. And the last one is a little bit more related with sleep disorders based on the hypnotic activity of this compound. Although all of them, they are not considered as psychoactive. Of course, the psychoactivity is a little bit debatable because cannabidiol can cross the blood-brain barrier and have an effect on anxiety, depression, and so on. So what are the limits? The limit between psychoactivity or no psychoactivity. Anyway, this compound, CBD, has very low activity to the cannabinoid receptors and most probably have this activity through indirect regulatory mechanisms. But it has been shown that it can act through a specific receptor in vitro and in vivo models about its activity on the bones. And also it has an activity outside the cannabinoid system in other type of receptors. And one of the most important findings of the last years is cannabidiol is related with cancer inhibition. We know that CBD has antiproliferative effects on the different types of cancer cells. And also has been shown to inhibit the activity of COX enzyme related with inflammation and indirectly with cancer, and also it has the activity to regulate the nuclear transcription factor kappa B, which is also related with cell proliferation and apoptosis. Most importantly, with CBD, we have several clinical trials. I would say today that we're talking, there are about 300 or 400 clinical trials that are ongoing. But there are several findings that have already been published about, especially about the antipsychotic effects on Parkinson's disease, and also the activity of this compound in ulcerative colitis. And also we have the activity on CBD on reducing the opioid addiction, which is something very, very interesting. And also we have activities related to the cognitive impairment in schizophrenic patients. All those are results from clinical trials that have been completed very, very recently. So we know that these compounds are active, we know that we can use them, but how we can use them? Well, actually the cannabis, as I said before, is already in the pharmacy. I'd like to say a bit more things about the regulation of these compounds in Greece, as I assume that most of the audience are coming from Greece. So it's important to know that the main limitation was actually the main change was performed in 2013, where the products coming from the cannabis plant containing less than 0.2% of THC were excluded from the list of illegal drugs. And this big change allowed the legal circulation of hemp products containing the non-psychoactive cannabinoids like CBD, CBG, or CBN, the legal circulation of these products in the market. Many such products, without being officially characterized as food supplements or medicines, are available in the pharmacy stores and also other commercial stores in various forms and various uses of characterizations like cosmetics, mouthwashes, pet care products, fragrances, vaping products. All these are legal. But in the pharmacy store, okay, it's not so clear what is the position of the cannabis products. Cannabis products are used as food supplements. Well, actually, the national authorities in Greece have tried to regulate the use of cannabis products as dietary supplements, and at this point that we're now, it's considered that only the products coming from the edible parts of the plant, the seeds, the oil, and the seed flour, but not the inflorescences of the plant, not the flowers. All the rest can be considered as ingredients of food supplements. The products coming from the flowers of the plant, from the inflorescences of the plant, are actually considered as novel foods, and we're expecting a formal decision about their use from the European Union. In the pharmacy stores now, we are expecting in the next, probably in this year that we're now, that we will have officially recognized medicinal products, finalized medicinal products coming from cannabis with THC content higher than 0.2%. This is a big change because until now, this type of products were illegal. Now they will be permitted to be used in the pharmacy stores with a restriction that the whole cultivation of the plant and the whole process for the production of the pharmaceutical products has been performed in areas that have very, very strict conditions and very, very carefully monitored. These type of products with a high THC concentration will be used for the prevention and treatment of severe nausea and vomiting during chemotherapy, and also for the treatment of chronic pain, treatment of spasticity related with multiple sclerosis, and also increase of appetite. All those products will be used as a secondary, not as the first line of medication. Of course, all these products will be prescribed by the medical doctors, and as it also happens with the products that are already in the market, like Sativex and Epidiolex, they are officially prescribed. They cannot be found in the Greek market, but they can be imported in Greece. So in that case, the role of pharmacist is very important, because the pharmacist must be very, very well educated on the activities of this product, and also about the possible side effects of this product. And also we have the role of the pharmacist to inform the patients about what will happen when they are going to use the cannabis products. As I said before, we have the new legislation that will permit the use of the finalized, I repeat that again, only the finalized medical products with a high THC concentration will be permitted to be used in the pharmacy stores. And this is a big change that has happened in the last years. And there are several risks about the medicinal use of cannabis, and there are several side effects that are related about especially activities on the central nervous system and the loss of interest about life, and several things that are well known about the use of cannabis. And also there are unknown risks now, because we have several ingredients that are found in the market. You can find, this is an ingredient, I found it in a shop in the center of Athens. It's called hexahydrocannabinol. It's a psychoactive ingredient, very psychoactive compound with unknown effects on the human body. But you can find it everywhere. So that we need a very, very strict regulation about how to use all these products. And I would like to finish my talk mentioning a few things about what we have done in the research about the cannabis in the laboratory of pharmacognosy. And our main interest is on the development of analytical methods, how we can measure in a very, very quick and rapid and reliable way the concentration of the active ingredient, the phytocannabinoids in cannabis products. You can see examples of the NMR spectra of all the pure ingredients of cannabis, and how in one spectrum, just in 30 seconds, without having standards in our hands, we can quantify the active ingredients in any type of product related to cannabis. I repeat it, just in 30 seconds. And we have developed all this methodology. And also interesting, we can measure the cannabis in olive oil. There are numerous products in the market that are circulating using cannabis extracted in olive oil. And also we have examples of two-dimensional NMR that can help us to measure the concentration of these ingredients in a very easy way. And we have compared with all the standard methods, and we have seen that this method is very, very well reliable. And the last thing is that we have developed new derivatives of cannabinoids with using a very simple methodology of synthesizing derivatives. This is this figure shows the structures of the compounds that have been included in a very, very recent patent that belongs to the University of Athens, has been developed in our laboratory. And just starting from the raw material, just starting from a plant, rich either in THC or CBD or CBG, in one step, we can perform extraction and chemical modification, and we can obtain derivatives, esters of the cannabinoid acids, the phytocannabinoid acids, with increased activity against the inhibition of cancer cells. This is an example how we have modified one compound which is called the CBG, the cannabigerolic acid. In the butyl ester form, it has high increased activity against the cancer cell lines. It's just an example, and also the activity of in specific channels that are found in our brain. But this compound is not psychoactive, and especially, and more importantly, it's not toxic. After oral administration, there is no toxicity, so we have a very good candidate for further development. And I'm very happy that this product, this compound, belongs to the University of Athens, and hopefully in the next years we will find a way to make it as a commercial product. And my last slide. Again, through our research in the University of Athens, we have developed this product which contains the active ingredients from olive oil, the polyphenolic compounds from the olive oil, which is going to be available in the pharmacy stores until the end of this month. And the most important is that we have discovered the unique synergy between the phenolic compounds found in olive oil and the activity of the phytocannabinoids. And we consider that this is a very, very important finding that will make more effective the activity of both types of ingredients, both of olive oil and both of phytocannabinoids. And that's all. I would like to thank all those people. Thank you very much for your attention.
Thank you, Dr. Macheras, for the nice presentation. Any questions from the audience? Yes, please.
I'm Bialer. I'm a former student of Professor Rafi Meshula. He's my mentor. So you enter into an open door. You just died 2 months ago.
Yes, yes.
Now, international, I don't know, in Greece I trust what you say, but in the international arena, there are only 2 drugs, CBD and THC. Cannabidiol was approved in 2018, Epidiolex by GW Pharmaceutical, now Jazz, 10 milligrams in sesame oil. So question number 1, do you think that and they use sesame oil because before there was dronabinol or marinol, which was THC in the same sesame oil. So the GW, now the question number 1 to you is, do you think that if I change the sesame oil to olive oil, because you are an expert in olive oil,
yes,
and you will improve the activity, and I go in epilepsy, that's all.
Thank you. Okay. Thank you for this very, very interesting question. Yes, yes.
I know that Epidiolex, GW, in order, because you're a professor of pharmacology, in order to keep the herbal remedy, they don't synthesize cannabidiol, they extract it from field of cannabis sativa, enriched, utilizing Mendelian rules with cannabidiol, and also it still contains 0.1% of THC. That's unavoidable. Do you think, as a pharmacognosy, that there is a difference between a herbally extracted cannabidiol compared to the synthesized alamarinol? I don't think that there is an entourage effect, what they call it, you know? But
well,
I would like to
thank you very much for those very interesting questions. And you know, Professor Mechoulam was a figure.
You don't have to tell me.
Yes, it's a figure in the field of cannabis. So what we have found from very solid scientific data and experimental results, that the phenolic compounds found in olive oil have a synergistic effect.
Are they also in sesame oil or only in olive
No,
oil?
the phenolic compounds are found, this specific type of phenolic compounds are found only in specific types of olive oil, not all type of olive oil.
The Greek olive oil.
No. Okay. Well, actually, there are types of olive oil in Greece that have very high concentration of these compounds. These compounds are not found in sesame oil, not in any other type of vegetable oil. So I'm definitely sure that if you combine the CBD with an olive oil with increased concentration of phenolic compounds, we will see an increase in the effect.
So with Panos, file a patent, and let's see if the patient with epilepsy.
Well, there is already a patent in the United States about the combination of this type of compounds. The second question is about the herbal origin or the synthetic origin. Well, actually, there is no difference between the synthetic or the herbal CBD. But what we have seen, and it also has been discovered from other scientists in other countries, that small amounts of other cannabinoids can have a synergistic effect with the main cannabinoid. So even just 0.1% of another cannabinoid coming from the herbal origin of the drug can probably have an effect, small probably, but important effect on the activity of the pure compound. So in my mind, probably the herbal origin is a little bit better than the synthetic. But this is it's a complicated story about the certification of the product and the quality control. It's
I disagree. Partly it can be because cannabidiol is a notorious inhibitor of 6. So it can inhibit the THC metabolism. So I'm not sure about the synergies. So, and the major problem with cannabidiol giving orally to children, it's the low oral availability.
Oh, yes.
Yeah, it's only 6%.
6% only.
Maybe
Yeah.
pure olive oil coupled with other tricky, what we heard earlier, with the lymphatic targeted.
Or sublingual. Sublingual administration can increase.
Yeah, but sublingual always jump into the esophagus, and then you get, we heard it yesterday as well.
It's a very interesting discussion about the administration of cannabinoids.
Another question? Yes, please.
I can try to shout.
Oh, you got a microphone.
Thanks a lot. I mean, 6% is really optimistic. I mean, in the studies I have done, yeah, okay. But, I mean, just politics and science. Just to give you the Austrian example. In Austria, it's okay for the physician to prescribe marinol, or in the pharmacy you can produce from the natural sources with sesame oil capsules. And the cannabis is grown by the Austrian Medicines Agency. At the outskirts of Vienna, you have fantastic greenhouses. So if you drive by, you have this, oh, great. But then, whatever you do, you have this low bioavailability. Inhale it.
That's 30% available.
Yeah.
Children cannot inhale.
Inhale it. Yeah. Why not? I mean, so everybody still have this reefer madness in mind, obviously. It's a great movie, by the way.
Oh, okay. Okay. Any other? A short question, please.
Since I guess you already mentioned, like you think the natural extraction for the cannabinoid is a better way to get this cannabinoid. Because so I was wondering which way is most cost effective if you compare the chemical synthesis and nature extraction.
Well, extraction from nature is easier to be done, but it's not easy to achieve the high purity that is required for the API. If you have an active pharmaceutical ingredient, you're required to have a very high standards of purity and quality. So this is the main difference between the use of the synthetic, or the synthetic is more expensive. But you can achieve higher quality on the final product. So it depends on the type of use that you want to do. If you want to inhale cannabis or vape, okay, the easiest way is from nature.
But you showed us cannabidiol,
yes,
which is a propyl instead of a pentyl, where
yes,
they found found a special cannabis in Pakistan, where they extracted it. But when they tested it in the bioavailability, as Helmut said, was even 2%, and the efficacy, nothing.
And now they are increasing this chain to even longer, and then you have a better activity. So there is field for with modifications, but okay, it's enough.
Also, they use a genetically modified, which has a content of 35% plus.
Thank you very much, Dr. Maliantis. I guess we can continue with our next speaker, who is Dr. Fokoloros from Amgen. The title of his presentation is Biosimilars in Clinical Practice, Opportunities and Challenges. I would like to apologize for changing the order. That was not deliberate.
Thank you for the kind invitation. I am a physician by training, specialized in allergy and clinical immunology, and I'm working as field medical manager in Amgen LASP. And we have the opportunity to discuss about biosimilars, a new trend in pharma industry. And as you know, biologics has transformed the lives of millions of patients with serious illness, like immunology disorders and cancer disorders. But biologics has a lot of costs. And as you can see in this diagram, we see the increase of the cost of development of biologic drugs. If we can see, especially in the oncology field, which across of the drugs, not only biologic but small molecules with specific targets, we see a lot of increase of the cost to develop new drugs. As you can see, a range in new oncology drugs we will see in the next 5 years. So it's very important to find ways to reduce the cost of the drugs to increase the viability for the patients. The reality of biosimilars is already known in the other, not oncology, but first of all the immunology field, with a lot of biologics in the monoclonal antibodies in immunology. And here in oncology we can see that the era of trastuzumab and bevacizumab in the US, after the introduction of biosimilars, we have a lot of decrease of the spending for these two major categories of therapeutic monoclonal antibodies in oncology. So biosimilar is actually a biological medical that contains immersion of active substance of already authorized original biological medicine product. And it's very important, especially for the healthcare community, to understand that it's very different by the generics. And this is based on the fact that biological drugs is very more structural and functional complex than chemical molecules. And here is the example of monoclonal antibody and the small molecule aspirin. And as you can see, this is based both in a scientific difficult to make these drugs, the time, the cost, and the manufacturing processes that it must be a company has to produce these molecules that is more like original biologics and not at all like generics. And the many difficult for a company that need to start to produce biosimilar is that they only know about the originator biologic is the protein sequencing. We didn't have any data about cell lines, growth media, bioreactor conditions, formulation methods. So we need to take a lot of different bunches of the originator product to determine the goalpost. We say that critical quality attributes, which is physical or biological properties of a product that may have clinical relevant implications, such implicating biological function, and we need to determine the range of the difference of the originator. So, as you can see, we can take a lot of different bunches of different slots of the originator product, and as a biological drug, have a difference by lot and lot. So we have to determine the range, the approval range of the originator, and as biosimilar, we must be in the same range as the originator. And here is an example of glycosylation, and as you can see, 32 different oligosaccharides must give us more than 400 different glycoforms of monoclonal antibodies. And this is very important about immunogenicity because a different glucosylation in a different spot maybe give us a different molecule. So it's very important in terms of clinical medicine. And the authorities has a standard procedure for approval of these products. Here in United European Union, we have a lot of experience, first of all, with small molecules like growth factors and hormones. And the last years, the last decade, we have a lot of experience also with monoclonal antibodies. And we have already 82 approval biosimilars in European Union and 29 approved biosimilars in the United States by FDA. And the main difference between the development of biosimilars and the originator is this pyramid. As you can see in the reference products, we start with the in vitro, in vivo studies, but in the top of the pyramid, we have a lot of clinical studies from phase 1 to phase 3 in every indication that we need to have an approval. In the other pyramid of the biosimilars, the main focus is the base of the pyramid, to find ways to make the biosimilar as much as possible similar to the originator. This is the in vitro studies. And we have only one phase 3 bioequivalence study in the top of the pyramid. So with this development, we have a smaller time to produce and demonstrate biosimilarity for biosimilars at a smaller cost. And the equivalence studies is something different, especially for the clinical doctors, because they already know inferiority and superiority studies. But in this situation, we need to find a similarity on efficacy and safety based on the specific ranges. If one biosimilar seems see a better result in efficacy than the originator, it's not a biosimilar, it's another drug. They need to run a different clinical studies to have been approved as a different drug. It's not a biosimilar. So to be a biosimilar, you must need in efficacy and safety in the same range as the originator. And we run only on phase 3 clinical study. It is very important to select the sensitive patient population and the sensitive endpoint. So most times we see clinical studies that is not on the major indication of a drug, but a more specific population that is more easy to determine the bioequivalence. And after the totality of evidence, this pyramid, based on the knowledge of the reference product and have seen no difference in the mechanism of action, pharmacokinetics, immunogenicity, and toxicity, we have that we say extrapolation of indication, and the EMA and FDA give approval for all the indication that the originator have already. So the SPC of reference product is the same as the biosimilar, and the biosimilar have in the end of SPC all the studies that have been already run in all the indication by the reference product. But every biosimilar have a different name. It's very important that in this situation we need to have a different names, and the doctor must be prescribes these drugs with the different names, because we want to know what every patient take every time, and this is the major problem of the switching, automatic substitution, and all of this that we will talk in the next of this speech. So substitution is the ability of the pharmacist to give an alternative biologic for prescribed biologic. Automatic substitutions is the ability of pharmacies to dispense less costly of preferred biologic regardless of prescribed biologics. And we have also the switching and the interchangeability, which is the ability to switch from the originator or between biosimilars. And we must have in mind that generic drugs all are identical, but in the biological drugs we have a little bit differences, and the approved biosimilar A have a little bit difference from the originator, and biosimilar B have a little bit difference from the originator, but we didn't make studies to see the difference between biosimilar A and biosimilar B. And this is maybe a clinical important decision to a clinical doctor to change from the one to the other and to multiply switching in the therapeutic duration of the treatment. So in the United States, the FDA have a standard procedure to mark a biosimilar as interchangeability. And you see there that the majority of states have passed the registration addressing biosimilar substitution. But in the European Union, the EMA has left this to the country authorities. Only in last year, EMA have issued a joint statement confirming that biosimilar medicines approved in the European Union are interchangeable with the reference medicines or with an equivalent biosimilar. But this don't give a guidance about automatic substitution. And as you can see in this slide, the majority of countries of Central Europe and North Europe legally regulation against automatic substitution. And here in Greece, we have a guidance prohibiting automatic substitution. This is the Greek Medicine Agency guidance on biosimilars, the last update on 2018, that said that biosimilars are interchangeable, but that must be a doctor's opinion, and not allow the pharmacist to change automatic to the lowest price or the preferable for the pharmacist. So this is very important, because we see that is in this era of biologic and biosimilars, the chain of the doctor, the patient, and the pharmacy is very important to determine which drug the patients will take. And it's very important because sometimes the patients must be changed without to know which drug take. As you can see, we see a lot of biosimilar adoption the last year. This is based on a lot of companies that have biosimilars and a lot of work to inform the health practitioners. But we have a lot of barriers to the clinical benefit, to the operation benefits, and the economics. Sometimes doctors don't want to know about the economic benefit of biosimilars. They just need to prescribe the originator, and this is a new era of how to use these drugs in everyday practice. Especially, we have a lot of biosimilars in the last years, and as you can see, we will have a lot more the next years as blockbuster brands lose exclusivity in the next years. And across EMA and FDA, Europe and USA, we have a specific policies about the authorization of those drugs. But we have a lot of markets like China, Brazil, India, with a lot of population, with a lot of space to decrease the cost of the drugs. And in this countries, maybe the policies may be different and the regulatory procedures. So it's very important to find, like European Union and USA, additional regulatory processes to accept an approved process which help to have a good products on biosimilar in these countries. In India, we have a lot of biosimilar that is not like Europe's biosimilar. It's with not the specific regulatory processes, and we must to find ways to determine that we have a strong policies around these procedures. So biosimilar cost saving, help to access medicine, and in the final, improve the outcomes for the majority of the patients. Thank you for your attention.
Okay, thank you very much for this very nice presentation. Biosimilars is a reality. It's changing continuously. There are so many challenges associated with the regulation. So the paper is open for discussion.
Thank you. Two questions with regards to, historically in the small molecule generic business, you eventually see that the innovator stops making their product, so you just have generics in the market. So in that case, you wouldn't have a reference product. You potentially may need to switch between biosimilars eventually. So I think ultimately that question will be answered. I was wondering if you could speak to the Norwegian situation where Norway, they've been using biosimilars quite extensively, and they regularly, as a nation, switch over from one biosimilar through a national tendering to another biosimilar, and then patients have to switch, all of them. And there doesn't seem to be Norwegians dropping like flies. So wondering what your thoughts are on that.
Yes, in the North countries we have the tenders, so every time every country choose one biosimilars for all of the patients and switch. So we didn't have studies to determine if we have monoclonal antibodies neutralized for these switchings, and we must know if that's safe. But the European, the EMA approved the situation for cost benefit and to increase the adoption of biosimilars, but we didn't know. Here in Greece, that we have access to all the biosimilars, and the doctor is the opinion on the decision maker. We tell to the doctors to don't change in the same patient's drugs. Start with one and continue all the treatment duration with the same biologic. The originator or a biosimilar, it's not a problem, but if we start with someone, continue all the treatment with the same. We didn't know, we didn't have evidence to the multiple switches.
Any other question, please? I would like to thank you very much for this very nice presentation.
Our next speaker is Dr. Kimarios from Nova Mechanics Ltd, Nicosia, Cyprus, and the title of his presentation is Towards an in silico integrated approach for testing and assessment of nanomaterials, from predicted indoor air concentrations to lag dose and biodistribution.
So, thank you very much for the introduction. I'm going to talk to you about the web applications that we have developed for the testing and assessment of nanomaterials, which range from predictions in indoor air concentrations to lung dose and biodistribution. So, first, a short introduction. Integrated approaches to testing and assessment provide a framework for combining information from different sources, experimental all in silico, for hazard characterization of chemical, which includes nanomaterials. The experiments, although the experiments to understand their biodistribution and clearance are costly and sometimes even ethically challenging. For that, the existing data are limited to specific only nanomaterials and rodent models. For that, computational tools are a promising way to assess the impact of nanomaterials on humans. This in a schematic, we have the literature information which we use in vitro or in silico methods in order to perform risk assessment operations. Now our work is in silico methods, and particularly I'm going to present you the multi-box web application, which we use in order to estimate the concentration of the nanomaterials in indoor environments. The lung exposure, sorry, you cannot see the pointer. Okay, I will try. So, the lung exposure, which computes the deposited dose of nanomaterials in human respiratory systems, and the PPK model, which concerns the whole body biodistribution of nanomaterial. So firstly, the multi-box model, as I said, we use it to evaluate the concentration of the nanomaterials in indoor environments. So what we do with the multi-box model, we have a room where the nanomaterial is released, and we divide it into different regions, which we call the boxes. And these regions are firstly the near field or NF region, where the nanomaterial is released. There is the location of the source generator. And every other area besides NF, it's termed far field. These regions can be cuboid or cylindrical. Concerning the source, these are emission rates of nanomaterials of specific mean diameter. An example you can see right down, where we have titanium dioxide of 22 nanometers or 560 nanometers, or black toner. These are some examples of rate emissions that we support in our web applications. So that sources have various diameter distributions, which we term as bins. And of course, we have different nanomaterials, such as I said, black toner, titanium dioxide, but also the user can specify their own distribution of material. The output is the concentration of the nanomaterial per bin per box. So a little bit about the underlying equation. I'm not going to stay in the mathematics. It is based in aerosol dynamics particle population balance equation, where we have this dn dt is the number concentration over time. J source is a single point particle generation term. It's actually the source that I was talking to you about before. The J exchange is the transport between the cave box and its connected boxes. J coagulation is the term that takes into account coagulation due to the Brownian diffusion and the number concentration change rate. J deposition is the removal of aerosol particles that adhere to the surface,
And of course, K runs over boxes and I over all the size bins of the release source. So this is the interface, actually parts of the interface of the multibox application. You can see first the room definition, where the user can define the actual room where the source where the whole process is performed. There it can define, the user can define the sizes of the room, but also the different number of the boxes that this room will be partitioned. And next to it you can see an example of how this room can is a sample of a room, the top view and the side view. Below you can see the nanomaterials properties, which is there we define a scenario. This is where we say if our material would be black toner or user-defined material, and below you can see in the graph the distribution of the diameters. And finally we have the simulation input where the user defines for how long wishes to integrate the equations. So we have the modeling time per cycle, and we have a time of the source being active in this cycle, and finally the number of cycles that the user wants to simulate. And finally some physical parameters regarding the actual problem. And here you can see a simple example. The computational details, we are talking about a room of 4x4x4, which is divided in two boxes, in two regions, one NF and one FF, with the NF being 2x2x2, the rest is FF. We used in this example black toner, which consists of, is described by 32 bins, and we performed computations for 300 seconds per cycle, with the source being active for 100 seconds and for 2 cycles. And next to it, you can see the example output. We have the concentration over time for every bin of the active source. So now we go to the lung exposure. We know we have the information about the concentration inside the room, but how do we use it in order to measure, to estimate the deposited dose inside the respiratory system of human? So we have this web application, the lung exposure, which calculates the dose of the nanomaterial deposited in the lungs. So as I said, we need the concentration of the NMs in the indoor environment, which come from the multi-box, and we need to define the deposited fraction, which is the part of the inhaled nanomaterials that are deposited in the upper respiratory system. The lung exposure supports different genders, males or females, ages, adults, teenagers or children, different nanomaterials and different exposed time. And as an output, we get the dose in the head airways, tracheobronchial and alveolar regions. The underlying model, we have two underlying models actually. One is the ICRP model, which actually are the Hinge equations that are fitted to the advanced ICRP model. They are simple analytical equations. But also we support the advanced ICRP model, which again is based on filters imposed in every region of human's respiratory system. And here you can see the interface of the web application. First of all, we define the concentration and the bins, which comes from the multi-box web application. Next to it, we see the input of the ICRP for the ICRP model, which is pretty simple actually. But when we want to use the advanced ICRP model, then the information, of course, is more detailed. Of course, besides using the multi-box model, the user can upload its own data, which can come from experiments or other simulation, as a plain text file. And the output is pretty simple. We have the acute dose for the different regions, the alveolar, head airways, and tracheobronchial of humans. So we use acute because here we care about small exposure times. But if we go to higher times, then this model is not adequate. We need something more advanced. And here comes the PPK model that it has been developed from our collaborators in National Technical University of Athens, which is used to compute the dose of the nanomaterials, but not just in the upper respiratory system, but in various organs of the human body. Again, we need the concentration of the nanomaterials. Unfortunately, this model, this PPK model, supports only titanium dioxide, but of course it takes into account clearance, which is very important. It depends only on the human's weight as an input from the user and the exposed time of the subject. And it gives us the dose besides the upper respiratory system for the kidneys, heart, spleen, brain, robe, liver, skin, and blood. And here is a test case that I'm going to show you some results. So we have the main question is what is the dose of a female or male sitting or during light heavy exercise for 600 seconds, which is our acute case, when the source is active for 100 seconds. And a working day, which is 8 hours, which is the chronic case, and the source is active for 15 minutes. And the room is 4x4x4, and the nanomaterial that we used is titanium dioxide. Here, below, you can see a schematic of the simulation workspace, and next to it, you can see the results that we have taken from the multi-box aerosol model, and we have used in order to feed them to the lung exposure and the PPK model. And this is firstly the results for the acute dose. I know the results are somehow overwhelming. First you see the results for the near field, where the subject is inside the box that contains the source. We have the results for female and male during sitting, light exercise, and heavy exercise. The black bars are from the lung exposure model, and the light gray are from the PPK model. And we can see that almost in all cases, both models predict the same results. This is something that we expected since at such short time scales, the clearance is not yet very effective. The same holds for the far field region. But note that between these two cases, the near field and the far field, the accumulated mass is almost half in the far field region, which the subject is away from the source. The results from the chronic, these are the same results, but for the chronic case, here we can see especially in the tracheobronchial and the head airways, we can see the effect of the clearance of the PPK model in both cases, near field and far field, which is the accumulated mass predicted by the PPK model is sufficiently lower compared to the lung exposure, since this takes into account the clearance mechanism. And this is over time, we can see that the accumulated mass up to the 8 hours increases, but as we close the source and we let the system evolve, we can see that in the tracheobronchial and the head airways, we have a constant decrement, but in the case of the alveolar case, we see a plateau, which is which means that the mechanism of clearance is not efficient in this case. So, from a physicochemical perspective, but from an algorithmic view, if we ask, do we know the external exposure profile? If we know it, okay, we can define if it is acute or chronic exposure. But if we don't know it, we can generate it through the multi-box aerosol model. And then we can ask ourselves if is acute or chronic the exposure. If it's acute, we can use the lung exposure model in order to predict the deposited dose. But if it's chronic, we have to go to a PPK model in order to do so. From the web application perspective, the software application perspective, we try to build easy to use generic web application. In the cases that I show you, we have selection of different materials for simulation and possibility of adding new materials, and we also have the ability to customize our workspaces. Of course, we try to make a fast software because this is crucial, but also it must be reliable. And finally, it must be flexible and robust. We have in our web application REST APIs, which are actually doors to be able to easily connect it to other software applications. This is something that we are doing now with the ProPlanet project, and I'm going to show you a sample slide of the project that we have, of the web application they are going to use. Every web application I do is freely available. You can find it in our cloud platform, and specific for the multi-box, the lung exposure and the PPK models. And recently, actually last week, we created an Android application, which is again freely available for your mobile phone if you want to play with these applications. And some other applications that we have prepared and we are working on. This is the web application, the physiologically based finding time pharmacokinetic models that we work with the team of Professor Macheras, which concerns drugs following linear deposition kinetics, such as where the term PBF DPKM is used, where P is the number of the successive input rates and M the number of the compartments. You can see a schematic of this on the right. Now we have gathered all this information in a simple interface, as you can see there, and you can actually integrate this equation behind this model and get the results, such results as you can see below on the right corner. Also, we are working on a more generalized web application, which is based in vivo nanoparticle delivery general model. Here we start with the administrator side, and we are trying to find the concentration from the administrator side of the nanomaterial to the target cell vicinity, and then to the target cell interior. And of course, during this path, we have losses from the administrative side and the target cell vicinity, which go to off-target sites. Again, this is mapped to a simple web application where these equations are integrated And finally, we have the synth box for nano. This is another kind of web application which concerns environmental exposure. This is what we are doing in the ProPlanet project I was talking to you about. It simulates the environmental fate of nanomaterials as fluxes between a series of well-mixed boxes of air, water, sediment, and soil on regional, continental, and global spatial scales. And it takes user-specified release rates of the chemical into the environment as input and produces exposure concentration in the different commanders of the environment as output. Here, again, you can see a single web application. We have the input on your left, and next to it, you can see the different regions that I was talking to you about. It's the global scale, the continental scale, and the regional scale. We're talking about the half hemisphere actually of Earth, where we can do such gradations. And next to it, you can see a flow diagram of the mass flows, which is an output of the software, and the concentration next to it, a sample concentration of the nanomaterials in the different compartments. So thank you very much for your attention.
For the nice presentation. Any questions from the audience?
Maybe I missed this, but I haven't seen any verification of the model and validation of the model. So have you compared it versus the real life exposure?
We didn't with the...
I mean, verification, okay, because it's...
Yes, we have verified
it's done, I guess. But
yes.
How about the validation?
But we have compared it with MPPT, which is the standard software for this type of computations, and it gives exactly the same result. Exactly.
That's verification. How about the validation? So comparison versus the real life exposure.
The real life, the model of which is based, the multibox case is based on a model which is verified with real data. And the PPK also is done so. I haven't shown such results here because this is part of, let's say, the scientific part, the research part of the world. Here we show only the web application, but the web applications are based on models that are both verified and
Can I find it in the paper which you referred to, or
you can find the verification, but I can send you the papers for the validation of the models.
Cool, great, thank you.
You're welcome.
Any other questions? Okay, thank you very much, Dr. Timarios, for the very nice presentation.
Unfortunately, we'll have to stop here since Dr. Doxikas gave us a call and he's not able to come for health reasons. Okay? So we'll reconvene at 15:15. Okay? So have enough time now. Okay? Apologies.